So far, it's whomever's behind the screen plus me. So
It's loud over here.
what I'm gonna do, if you guys are okay, you see how to use like the unmute button or the mute
Yeah.
button. Um, I was just gonna say, when you have a question, just like obviously unmute and then let me know. So far it's whoever's behind that screen, and then I know Ashley's coming around 9:30.
Okay.
So I mean
Let me. We have CPVH today, so let me see if
oh,
people have questions about it.
this is great. I just had I'm not sure. I think it's Campbell Lindsay in your
Yeah.
unit.
Yeah.
She just had CVVH this weekend,
Mhm.
and I was a 1600, so I was able to kind of walk through the process. And there was a group of you guys in the unit that we went over a bunch of stuff. So this is like a fun topic anyway. So yeah.
Will you ask Tori if she wants to come ask Mark some questions? Yeah. Tori has it today, and I don't know that she's ever had it, so she may
Oh,
have questions.
is it the same patient in that corner? I'm not sure if I
Yeah.
remember.
Yeah.
Oh, okay. Okay. Yeah,
There's
we
a
could
problem.
we can start from like scratch. How I usually like to try to go through just kind of understanding the system a bit. And
Okay.
so let me know when you guys want to get started. If you need to wait or more people to come or
Let me gather some people, and then we can get started.
yeah. I'm here for 4 hours. You let me know. I'm on your clock. And I'm terrible with this chat thing. I gotta figure out how to open it up. Okay.
Can you hear us?
I can.
Hi, Mark.
Who's that?
It's Tori.
Oh, hey.
Hey, so I'm taking care of the CVVH machine in 28. Can you see us too?
No, I can. It says
Hear us?
neurocritical care, but I.
Oh, okay. So we're flushing it every 4 hours.
Yep.
So I'm turning it off for the patient, and I'm letting the saline flush run through for 100 mLs.
Yep.
Anything I'm supposed to be pressing on CVVH during that time, because it's like it alarms negative access pressure, and I just keep pressing silence, and I want to make sure I'm not just screwing anything up.
No, so just kind of keep in mind, like the viscosity of blood is thicker, obviously, than the saline. So when the machine is kind of running normally, it's kind of like pulling at a steady state, and it has a certain pressure that it's sensing for that pull, that drag.
Yeah.
And then when you turn that stopcock, you've gone from something that's kind of like thick to something very thin, and all of a sudden you have a dramatic change in a pressure. So the machine senses that, and it doesn't know what you just did. It's kind of like giving you the idea that, ooh, maybe your catheter actually just became disconnected.
Oh, okay.
And so the change in the alarm makes sense, and it's, if anything, it's good that it alarms, because it's doing what it was meant to do. It's sensing a dramatic change. Like if it was like a subtle change, you probably wouldn't get much of an alarm, because it'd be very subtle and it would drop a little bit and then it would come back up. But when you do flushing, it's kind of common for the access pressure to be very dramatically different than the blood when you switch it over to the saline. So very
Okay.
yeah,
Cool.
no, yeah, you haven't done anything wrong. I just
Yeah.
I just
I was
recommend
like, ooh.
I just recommend that when you are done with your saline, just I'm not like super clamp happy. I'm just like a roller clamp kind of guy. So like just that one roller clamp. That way on just if your patient was ever to be restless or something, and somehow that stopcock gets turned back off to him and then goes upwards to the saline, you haven't like oopsied and given them a whole liter that you didn't mean to do, because now that's in them, and you've given them a nice fluid bolus. But maybe you weren't trying to. And I know that we spoke the other day about the UF. So are you guys at that point where you're actually taking fluid off?
Yeah, I knew exactly what to do when they asked me to start taking fluid off thanks to your little class, which was awesome. So thank you for that.
Yeah,
it was very helpful.
No worries. And you said you never had it, so here you are. You have it.
Here I am. I have it. I'm psyched about it.
Has it been running, or has it been clotting off?
It runs really well. The TMP got up to like 300 and it had started at 180 yesterday. So they came and changed out the circuit at like 6 o'clock last night.
Yep.
And it's back to running really well again.
Great.
Yeah. And then the only other thing that I thought was a little weird when I came on the shift yesterday.
Yep.
So that little chamber with the blood and the saline that sits on top.
Yep, the air chamber.
All blood. And there was no like meniscus with saline. So I just like had adjusted the fluid level up a little bit and it like eventually came back. Is that just from like the fluid level being too low?
Yeah, so sometimes when the blood, like that whole chamber gets dramatically low and you're like, oh crap, it's been a while since I've had to raise it. When usually when you hit the button to like push the arrow up and you hold it and it finally rises, usually it's been mixing so much, so don't worry that you don't see anything. That's okay. It will if you've noticed, what will happen is as soon as you raise whatever the top layer is, so in that case, if you're not seeing any saline layer, you're just raising the blood to that elbow.
Okay.
And then what will happen is as time goes on, you'll notice that there will be a nice saline level that starts to be created.
Yeah.
And then it'll all be okay. It's just that you probably went so low that you've had to dump, and what it does is it mixes, so you don't get that nice, beautiful like separated layer. I was
like paranoid it was all going to clot off because what you said about the saline sitting on top, and I was like, oh no.
Yeah, I mean, this is just like one more way for that system not to clot, but you know, and for him, I know he's not on citrate. So had they been on citrate, you know, you're probably okay, but it's just like I said, that one extra piece where you're not exciting the extrinsic pathway, but that happens. Don't worry about it. And like I said, it gives that opportunity for blood, or if there's air in the blood, for it to rise. And then when it rises, it has a chance to go all the way through, and that saline level, is just kind of keeping it from the always touching the air, you know.
Okay.
So yeah, don't worry about that. That's kind of a common thing. And again, if you pay attention to it after several minutes, you'll notice that it will completely separate, and you'll see blood here, saline there. You're good. The only thing you don't want to do is make that blood level go all the way down, and then it goes past the elbow of the blood actually coming in, which is below where the saline's coming in.
Right.
Once you get there and it sucks it down, game over. You can't return blood, and they have a tubing full of air on the return side. But that system will sense that, and it will not allow you to go into lockdown mode.
Okay.
Yeah.
Okay. Cool. Thank you very much.
Yeah. You were talking about the CVV, not Tori, but Shannon was talking about CVH. Are there people there that kind of want to go through the whole steps and like understand stuff, or I don't know who's behind the scenes. I know you said there's a few people.
Emma got it already. I don't know if Mary wants to.
Right now? Yeah.
Yes?
Yeah.
Yeah.
To go through the whole thing?
Yeah. We have another new orientee here who I think would like to learn about it, Mary.
Sure. Okay.
Mary, Olivia. I'm getting confused with all our orientees again. And we're just Shan's gonna walk over to Scoochie real quick and see if there's anyone else over there.
Okay, I can wait, and then just let me know when you guys are ready. And what I'll do is I'll switch it over to the whiteboard, and
cool.
and then I'll do my doodles.
Cool. Thank you so much for all your help. It totally made it like so much easier to walk into that room and like take care of it, and it was good.
Great. No worries. I I'm happy I can help. All right, let me see. I want to do whiteboard. And I'll switch that up.
Which is great.
And while you guys are trying to figure out who's going to come, let's see if I can figure out how to draw. Whoops, I did not mean to do that. How can I move this thing out of the way?
Whoa. What are you drawing?
Doodles, I guess.
I think you have an audience if you want to start.
All right, let me just double check
You want to
myself.
hear about CDDH?
Yeah, I'll go through all of it. I'm just trying to check myself if I'm remembering this right. So let's see. Just a quick. Yeah, this part. Okay, let's start over. Clear it all. I mean, this really doesn't matter, honestly. The numbers. This is not really what I'm trying to get at, to be so specific. So if you want, I can just even. Boom. This is 12, and this definitely starts at 7, right? It's been a while. Oh, okay. And then the big one here is 10. All right, so if you get a little group of people, what I like to start off is just kind of understanding the clotting cascade, but not really understanding it, just getting at a couple points. So you have something called the intrinsic pathway and the extrinsic pathway. And what this simply means is that if there's something internally that gets injured and there is damage to the vessels and you start to have bleeding, you excite the clotting cascade over here at factor 12. And then there's a series of events that finally get you to factor 10. And then from that point on, there's a bunch of series of events that get you to this fibrin clot, right? But on the outside of your body, so if you have trauma on the outside, get a cut or something like that, you excite a different pathway, the extrinsic pathway, which starts with factor 7, and then it works its way to 10, but then after 10, both of these end up to the same thing. So basically at this point on, this whole pathway is the same. It just starts at a different point. But what I want you to understand is that for the majority of these clotting factors to do, one to the next, so 12 to 12A, blah, 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 there are some that use vitamin K, and I can never remember them all. It's 2, 7, 9, and 10, I think. I think it's 2, 7, 9, 10. But there's a lot of them that require this beautiful thing called calcium, okay? So I often kind of lead in with, have you ever wondered, because my brain back in the day when I left nursing school and started in the ICU, hung a bag of blood, for a patient, and then I'd sit there and ask myself, and I wouldn't say it to anybody because then I felt a little embarrassed that, wait, should I already know the answer to what I'm about to ask? So of course I kept this a secret, I never asked. But why is it that if I cut myself on the outside of my arm and, it starts to clot off, what happens to that blood that ends up dropping down on the ground and covered all over my arm? Well, it dries up, it clots up, right? Sorry, thank you. Sorry, I'm just gonna hit, there you go. So it clots off, right? But then, you hang this bag of blood that's cold and it's and it's just in a bag. It's outside of the human body, but yet it's somehow in a liquid form. And I was like, should I already know the answer to this? Like, I don't know if I skipped that class in school or something. I was a little bit like, I'm not going to ask the question, but why the heck is the blood up there wet? It's wet. I don't get it. So it took me a while. I'm not going to lie. It took me a long time to really understand this because I never really got taught, nor did I ask. So it's part of my own fault. But you have this beautiful thing, like I said, called calcium. And then we have this substance called, that's citrate. Sorry, I have this pen thing and I'm not the best at drawing and it's hard to do this. But this is citrate, okay? And what citrate does, my beautiful analogy that some people have heard over and over, is like an Easter egg, right? Those little plastic Easter eggs that you see that are like probably a penny each, and you hide some change or $1 in there or something like that for kids or adults, whatever. Well, I look at citrate, okay, as being like an Easter egg. So this is what binds calcium and makes calcium unavailable, okay? Not gone, not missing, just unavailable. So it's bound and calcium is not able to participate in any of these processes, which means if there is no calcium present anywhere along the lines here, I can't ever get to the endpoint. I can't clot. So when you have a bag of blood that's just hanging, right, it's basically been injected with a lot, I always think of it as oversaturated, and there's a reason why I think this way, right? Oversaturated with this product, citrate, and what it does is it binds all of the calcium in that bag of blood. Believe it or not, there are clotting factors in that bag of blood, but it can't clot for this reason, right? So if anybody has worked with patients who've had a lot of blood products, maybe to the degree of a mass transfusion, that's obviously an extreme, but maybe you just have a patient that's been really sick and requiring several units of blood maybe throughout your shift, but not like, crazy, get the Belmont and start going crazy with it, but, still requiring a lot of attention, a lot of blood products, transfusions, things like that. There's one thing that you may have been taught, I don't know, but you always want to look for something called the ionized calcium, okay? And the reason for that is that when I deliver a bag of blood, it's oversaturated with this citrate, which means there's citrate sitting there that hasn't, caught any of the calcium. So when you administer it into your bloodstream, not only do you have citrate that's already bound all the calcium within the bag of blood, but then you have this citrate that hasn't done anything yet. You deliver it into their bloodstream, and now you have this free-floating calcium that's just, ready to be caught up. And so after several units of blood, I think somewhere past 2 is in my brain. If I'm just going to give 2 for that day, I'm probably not going to think about it unless there's other things going on, right? But generally speaking, if I'm given like maybe 2 units of blood, maybe I don't really care. But if I'm giving a patient a lot of blood, especially again in a mass transfusion, I'm gonna be giving them all of these units of blood that have citrate that haven't done anything yet. And so therefore, all of this citrate, once it's administered into your bloodstream, is going to start sucking up, if you will, all of the calcium that's actually in the bloodstream outside of what it already did in the bag of blood. So this is how that bag of blood stays wet, okay? And so if you've ever, we've all been told when you administer blood products, especially the RBCs, right? You're always told to use normal saline. That's normal saline, right? But why? Well, if you look at something like LR, you'll notice it has calcium in it. And when it has calcium in it, the chance of administering it while it's dripping into the patient, you could start to form a clot, potentially. Likelihood probably very low, but we still never want to take a chance on a patient, right? If there's anything we can do to possibly help our patients and not have any sort of event, then this is the rationale behind why we don't give other things with our blood products, because if there's calcium present in that blood, or that fluid, then there's a chance for it to clot, and we don't want that, because now you might be sending in little micro clots into your patient. And you have big vessels, then you have really tiny vessels, and maybe you put a little clot there, and then an infarct happens and something bad, right? So I draw this because a lot of people, they've heard, they've even seen, maybe even on orientation done or worked with a patient that's on CVVH. Then they've given units of blood, and they know that they're giving the citrate for their patient on the dialysis machine or the CVVH machine, but they haven't put 2 and 2 together. And so I like to point this out because this is something that's similar between the two things. This is why we give citrate while we are on CVVH, if we're able to. But you need a liver that helps sort of take this and crack it open and release this guy within, so then you can clot. So this is like the first step I like to point out, is what is this citrate and how is it actually present in, probably, I wouldn't say daily practice, but often practice, way more than CVVH, right? You administer blood products all the time, maybe once a week, who knows? Especially on the surgical side, people are cut and oozing and bleeding. So, a lot of products there. So this is like the first thing I'd like to show. Anybody have a question there before I kind of continue? Got it. Oh, I'm so bad at this. Hold on. I know there is a, is this? No. Shoot. There we go. It's hidden. I'm trying to find the comment section. I'm so bad at this comment section thing. The chat. Okay. Just in case anybody has a question and they're typing it, I can see it now. Okay, so now you have this beautiful machine, right? All right. So you have these 4 scales on the bottom, and they kind of all do different things. So this first one on the CVVH machine, I'm just going to push it over here, is your effluent, which is your urine, plus some other stuff. I'm going to put a plus there. All right. Your second one is your PBP, pre-blood pump. Pre meaning before the blood pump, this little guy right here. Okay, and we call this replacement solution. This is replacement solution, not to be confused with dialysate. Okay, and then we have a bag of normal saline and another bag of normal saline. So we have 2 bags of normal saline, and this is how they are in order. Okay, so when you approach a machine, you're going to see this in order all the time. It should always be like this. Okay, and so you have your patient. I'm a terrible drawer, so there you go. Okay, and they have this nice dialysis catheter. So let's look at the dialysis catheter for a second. We have one catheter, so we see usually 2 lumen that come out of it, right? And we have, what you don't see is the piece that's inside of them. This is the part that's outside of them. And this is the vessel that's inside of them. Okay? So we know that blood is running in this direction, this way. Okay? And we have a red port and a blue port. And we often say this is arterial, which is actually incorrect, okay? Because this is 1 lumen in a vein, right? So CVVH, continuous veno-to-venous, veno-venous, so vein-vein, hemofiltration, also called CRRT. I think there's a bunch of other ones. Continuous renal replacement therapy is another way to describe this. And we're doing replacement solution, not dialysis. And I know that this machine can do that. We've just never done that, and I'm not sure we ever will do that. And it's just a different setup, and it changes the way that these are all in order. This will be a dialysate, but we don't run this machine that way. We just run it as CVVH, okay? And so when I look at this lumen, remember, everything's happening in one lumen. It's coming from the vein and returning back into that vein. But we signify red and say arterial, so kind of just take it for a grain of salt here. And what we're thinking here is that when we pull blood from the patient, okay, we want the blood to come from the patient from this port. So this one would be red. Why is that? Well, this machine is going to clean their blood, right? So I want to suck up blood here, but then when I clean it, I want to put it back down here because blood is going in this direction, down, right? But sometimes you might hear the nurse say, okay, we've cath flowed it, or maybe we turn our patient and it kinks off so much that it can't really suck very well, so you hear, access pressures high or return pressures are even high. So sometimes it's not the sucking action as much as it is, it won't push into it because maybe it's kinked a little bit, or maybe there's, some clot forming and it just won't, it's a little sluggish with its flow, whatever the reason is. Sometimes, so in that case, what you might hear is that, we had to reverse the lines. So what you would like ideally is the red tubing that comes from the machine. You would like, hopefully, red to red. And then you would like, hopefully, blue to blue. Because then you would get this scenario. You would get access from the red, you would clean it, and when it would come back, it would get returned downstream. The problem, and it's no big deal, so if at any point, whether it's the dialysis nurse or maybe it's you guys, at some point, you're trying to troubleshoot your machine and you keep getting these access pressures, whether it's I keep saying access, but whether it's the access or return pressures, but either way, you're getting some issue. Sometimes what you can do is stop the machine, clamp everything, and you can swap them. So then what happens is, instead of having, oops. I did not mean to do that. Instead of having the red be on the red's actually on the blue, and the blue is actually on the red. All that means is that instead of 100% efficiency with cleaning, you might have knocked yourself down to about 85%. Because what's happening is you're drawing from now down here. If this one becomes red and this one becomes blue, because the catheter never changes, if this red gets connected to blue, what you're doing is you're sucking up downstream, but then you're returning higher, which means as blood goes back this way, you're kind of re-cleaning some already clean blood. Is that hurting the patient? Absolutely not. It's just not as efficient. And there's no harm to the patient. You can do it. The dialysis nurse can do it. It's just how we kind of figure out, how do we keep this machine going? How do we keep cleaning? How do we keep taking fluid off? All of those things. So it's just better to understand in my mind how this catheter works, because we often say, the red port is arterial. This catheter doesn't matter. What really matters is where the red is, where the blue is. So if blue is on blue, you know what's happening. If red is on blue, then you know they got swapped, and you're kind of in this scenario now where the red becomes down here and the blue and the return gets here, right? So that's like how that catheter works, right? So now what we want to say is, how do all of these things factor into this catheter? So as the blood, if we have the beautiful scenario where red is on red, blue is on blue, then this pre-blood pump, we're going to start with this one first. So the pre-blood pump, and I'm sorry, I can't really draw this very well, so I'm just kind of wing it. But if this catheter, or sorry, this tubing, not catheter, but if this tubing here from this catheter here, this tubing, that is actually accessing, pulling blood this direction towards the dialysis machine. Whoa. Towards the dialysis machine. And this machine, as blood is being pulled out of your body, you're going to start having the excitement of this clotting cascade that we just spoke of. So I'm going to start to clot my machine if I don't try to do something for it. So we have different methods. The best way we can do it is to anticoagulate just the system if we can, which is the citrate we were just talking about, right? So if you follow it, these are different colors. This one's yellow, this one's white, this one is the green, and this one is the purple, okay? And what you'll see is this white one kind of goes like up into this system here. These cogs here, I call them cogs, but these four up here all are part, like this one spins because it's connected to this one. This one spins because it's actually this one to this one, this one to this one. So it's how fast you've programmed the machine to spin these things. And this guy right here is just typically 150 mLs per minute. That's kind of a normal standard blood pump, okay? So the blood pump is just spinning round and round, and it drags blood from the patient up through the system, over to the air chamber, really down here, and then back to the patient. So this guy is driving the whole thing. And these four little guys are spinning whatever you have programmed for these rates. And I say you, it's really the dialysis nurse, okay? So as blood gets pulled in and we don't want this machine to clot, then what is citrate's purpose? Well, citrate, this line, runs exactly along this axis line and immediately gets dumped in right about here, like almost as immediately as the blood gets pulled from the patient. If we zoomed in, this would be like the patient's line. Blood would be coming out of their body, and then almost instantaneously, this is the citrate, and blood is going this way, and basically citrate is getting mixed right here, all right here. So all of a sudden it's binding all that calcium. And so as it travels this way towards the blood pump and then eventually to the filter, it's actually anticoagulating because it's taking all of those calciums and it's putting them in my little Easter eggs, and they're not available. Not missing, not gone, just bound, not available. So therefore, that whole clotting cascade can't happen. All right, so far, so good? If I don't hear anybody, I think it's okay. So this is sort of like the first action. So as it goes through, you're gonna see the blood get pushed around, and I'm kind of shortcutting this, so there's obviously more tubing, and then eventually goes up, and then these little green and purple ones, they're like up in these little cogs, and you'll see the green one kind of go in here, and you'll see the purple one going in here. So this one would be purple, that's not a P, that's an R, okay, that's a P, and this would be a green, okay? And you know, I asked the question a long time ago and how I got taught about green, and actually I just learned some new stuff, so putting kind of 2 and 2 together here for myself and for you guys now, is that for the green normal saline, remember, normal saline, why normal saline? Don't want another product that has calcium in it, right? So this is why normal saline. We got blood going out of the body, we're mixing it around, we're doing stuff with it, we're in this case trying to use citrate, but I don't want to add any possibility of clotting, so therefore normal saline, right? No calcium. So as this green one goes up through one of these cogs, it actually gets pushed into that filter system. And how I learned this is that one is the saline helps to dilute the blood as it's traveling through the filter, so it has an easier time kind of getting things through all of those little tiny, I mean, those, if you ever see a filter, they are, there's those little capillary straws, and I think they're considerably smaller than those, but you have those little kind of straws just tightly knit into that giant filter that's about 100 cc's, and usually it's the M100, so the 100 cc's of blood that is always outside of the body, right? But what happens is it helps to dilute that sample through the filter as it's running. So that's one thing. And two is it actually helps with the process of convection, which is dragging solutes across the membrane so that they can come out. So it's kind of doing two things. Okay? So convection. Okay, so that's this purpose, okay, which is the green saline here. And then you'll see, I'm going to draw it over here, you'll see the purple one. So we're going to take this spot right here and we're going to kind of zoom in. Thanks for not complaining about my drawing because it's terrible. I'm also not very good at 3D. So you'll see that the blood tubing from this point, so after it's gone upwards, this is how it's getting cleaned, it's getting pushed up through the filter, and then it comes down and around. And when it comes down and around, it goes this way towards the bottom of this air chamber. And you'll see a layer of blood, okay? And then you're going to see, hopefully, a beautiful layer of saline. Okay, so this would be blood. This would be saline. So after it gets cleaned from the filter, it goes this way. Okay. And it dumps in kind of towards the lower third of that little air chamber. So that means at any given point, from this point when it comes out of the patient's body, goes through this blood pump, goes up through the filter, at any given moment there, if there was air in the actual system, this is this opportunity to actually escape. So then air, if it's present, will, as it rises through fluid, will start to go up and hopefully kind of go in here. And then this long tubing that goes up to this little blue nub looking thing, that's how the air will escape. The saline, so this purple one here, as the saline is going up into it and feeding into this chamber, this would be the purple saline. And it dumps into here. And the reason for that is that, remember the extrinsic pathway, right? So if we have trauma and we have air and we have something on the outside of our body exposing damage to those cells, then we excite the extrinsic pathway from factor 7, and then obviously we look down, it gets to 10, and then you get your fibrin clot, right? So the saline layer is kind of like, it looks like a shot, if you have those nice shots where you have this beautiful layer that it's one on top of another, the saline is nice and crystal clear, and the air in the blood has a chance to rises through the saline, but this buffer, this layer of saline kind of acts as a buffer or a blanket so that the rest of the blood is not constantly in contact with the air. So therefore it lessens the chance for the extrinsic pathway. And that therefore you're not exciting the potential yet again for any clots to form, right? So I'm trying to use a product that doesn't have calcium in it. I'm using something that actually anticoagulates and captures those little calciums. And then anywhere along the system, anywhere there's a connection, and if you really examine, if anybody who's listening actually goes into Tori's room and actually sees the Prismet, you'll see that there are connections galore, right? There's always these little not stopcocks, but little lure locks, right, all along the way, whether it's down where the bag gets spiked or tubing to then the filter, then above the filter. So anywhere there could be a loose connection is always a possibility for air to get sucked through, right? So if air gets into the system, boom, you have an opportunity for it to leave. And then behind this sort of curving in towards, like I said, I'm not a very good drawer. This is three-dimensional, right? So this tubing is actually coming from the front of it, going into the system. And then below it, right here, if we were to look behind this tubing, is going down the machine. So now the tubing goes this way and actually goes longer. And there's a couple of little clamps going on here. So if at any point this level of blood actually reaches down here and air gets into the system down here, this machine will clamp down and stop. And this is the time where it will not allow you to return that patient's blood, because now air has not gone from here, it's actually gone down the tubing, which means it's about to go into your patient. And we all know air going into the patient is not okay. You know, that's an air embolism. And if anybody doesn't know how to react to an air embolism, we can talk about that next. But this is like a no-no. So this is why there's usually a nice orange, it's a little old, and this is like a nice orange sticker that we have on the machines. And what they're trying to do is catch your eye's attention so that you're like, okay, you are running this machine, and you'll see that as time goes on, sometimes this layer of saline and blood starts to drift down and down and down. And so what you need to do is raise all that fluid back up. And it's not the blood. It's not this one that we're looking at. It's this one. So Tori kind of was just talking, if anybody came late to this chat, but Tori was talking about how basically there wasn't really any saline, that it looked like it was just all blood and it was kind of low. And that's because it's kind of dribbling down this way. And so when you start to raise it, you're kind of mixing it, so you won't really see a difference between a saline layer and then the blood layer. You're going to see primarily just a big old blob of blood in there. That's okay. Don't worry about that. You just have to give it time. So whatever the topmost layer that is visible to your eyeball, you want it level basically to the bottom of this elbow, okay? If you go past it, that's not a big deal. Don't raise it up here, because what's going to happen is the fluid's going to go up, get sucked into this tubing, and that will actually kind of, I don't know how to word it. It gets stuck, if you will, into the little air filter, and then that machine won't run very well. In fact, usually they have to come and change the system. And there's a little like filter, kind of like a little clear, not quite as big as an amiodarone filter, but a little clear white filter before this blue nub up here. So if you start jamming too much fluid and it gets sucked up in this little tubing, it might be game over for that setup, which means you have to stop the machine, return the blood, and then have dialysis come in and change your whole setup yet again. And that could be hours of time that the patient hasn't been treated. So try to just remember to keep the topmost layer, which should be your saline, but in the instance where you don't see it yet because maybe the blood volume drops so low that now you're kind of playing catch up, that's okay. So after you raise, if it's just blood you're seeing, that's fine. Get the blood to this level, and then the saline will start to drop down, push it down, and then you'll create this beautiful layer, this nice clear layer. You just have to give it a few minutes to actually see it. So just be patient, that's all. So its purpose is to sort of help prevent that constant exposure, again, to air, okay? And just always keep your eye on it. Now, the thing is that this replacement solution, coming back to this guy, there's pretty standard numbers when you start to start the machine, get the machine up and running. And so this comes from nephrology. And so they look at the patient, look at labs, and determine what the speeds of everything should be, right? But there are things that are basically like an order set that you get this number all the time. Things could change, but generally speaking, it's just like you don't even, after you've done the machine a few times, worked with it a few times, you kind of just know what to expect. So the citrate, or sometimes bicarb, and I know the gentleman that you guys are speaking of in the corner is actually bicarb, but you'll see that the rates that we run the PBP, or pre-blood pump, is 2,000, 2,500, or 3,000. And that's cc's per hour, okay? So that's like if you had a citrate bag, that bag, so citrate is 3,000, the bag. If no one's ever seen it, or if people seen it from afar, the bag itself is 3,000, which means in 1 hour I would have given the entire bag into that patient. That sounds scary. I'm putting it into the patient. Now, just going to take a side note for a second, but just to be clear about dialysis and then CVVH, this one in dialysis, the blood never touches the filter. I mean, sorry. That's not what I meant to say. Sorry. My bad. It never touches the dialysate. So at the filter, sorry, the blood is going in opposite directions, but this is never touching this. And I know, never have I experienced it in my career, but I do know from talking to the dialysis nurses that if there was a leak detected by the machine, which means somehow the dialysate and the blood touched each other, it's like a big problem, because you're using this water that, and I don't even know how that system works, but if you've ever seen them come through with a dialysis machine, it's a two-part process. It's like the machine, and then there's these two like pumps that kind of look like giant O2 tanks in a way, and then they take the water from the faucet, but underneath with these connections, and it runs through, and then that's what helps to create the convection process. But it goes into the toilet, right? So at any point that the filter breaks and the blood touches the dialysate, it's a stop immediately. And I know that it's a big deal. There's labs, there's like a hepatitis panel, there's like antivirals, all of the stuff that's a big problem. But just keep in mind that the dialysate doesn't go into their bloodstream, right? It's just this sort of side-by-side kind of action. CVVH, the products you're using go into the patient, physically go into them, right? So we just said that this PBP mixes right here. So it comes off this line, goes and right here. And this is the zoomed in picture that citrate actually goes up and mixes immediately with the patient's blood, or in the patient that you guys have is the bicarb, would mix immediately right here and start to anticoagulate the system. So that's right here at this point. So at 3,000 an hour or 2,500 or whatever, that's going into their bloodstream. So in 1 hour, think about if you put 3 liters into your patient, right? That's a lot of fluid. And that's in 1 hour. Now you're running this 24 hours. So they would be exponentially bloating and would probably explode all over the room. But notice it doesn't happen that way. And I'll explain in a second. And the combination of these two right here is always 300 cc's an hour. This one is faster than this one, because this one is pushing through the filter. So you always notice that the green one kind of runs out faster than the purple one. And it's like, you'll see up here, it's like 70% and 30% based on these two. Don't worry about all that. That just is basically saying I want this one to go really fast, this one to go a bit slower. And collectively, they make up 300, these two salines. So let's just take a scenario. You take your citrate, the doctor orders that we're going to run the citrate at 3,000, and we're going to not take any fluid off the patient. So at this point, we just want to clean their blood. So I would have going into them 3,000 plus 300. So 3,000 from here and 300 in 1 hour. That's 1 hour's time. So scary. They blow up. But that's not what happens. So what happens is that as these solutions are actually going into the patient, the machine is also taking it back out. So it's kind of like a one-to-one. So think of it like that. So if you've ever seen it from afar, you'll notice that this pee-pee bag, if I was taking nothing off my patient, basically there shouldn't be anything in that bag, right? The effluent bag. But you see this thing growing, because as the volumes from the replacement solution and the two salines actually start to go into the patient, it sucks it right back out. So it's doing its job. It's like, here you go, and I'm taking it back. Here you go, and I'm taking it back. So this effluent bag is a 5,000 cc bag, which means in 1 hour, I should have, if I don't take any fluid off my patient, at the end of an hour, in this big old 5,000 cc bag, I should have the combination of these two things. These two things will be in this big old bag right here. And that's the effluent. And you'll notice it turns yellow because it's taking out bilirubin and it's taking out urea and all of the things, as well as electrolytes. Okay? So that's how these bags kind of work. So let's go back though to the citrate. We said, okay, citrate basically is this Easter egg, and it binds the calcium, so therefore the blood should not clot. So therefore, as it's going through the filter, it's not clotting it up. But it's not 100%, right? You know, there will be some calcium that makes its way through that didn't get snagged up, right? But overall, this should be doing what it's supposed to do, which is anticoagulating the system. But then you're kind of anticoagulating your patient because, again, this goes into their bloodstream. So how can we offset that? Because if I don't do anything to offset the citrate, then hour by hour, I'm not sure how many hours it would take, but eventually all the bioavailable calcium would be basically bound, not useful, and your patient, I would imagine, would hemorrhage and die, right? Because there would be zero calcium present or bound, not for utility, right? So you'll notice that at the end of the circuit, we always have this beautiful plumb pump that has calcium gluconate. And it's really, really simple to run. And just like the citrate, how it immediately interacts the moment it comes out of their body, this is immediately returned into their body, right? The moment it's about to go back in, right? So it's kind of intertwined with a little, like a Y connector, and it is pumping calcium gluconate just as it's going back into the body. So as that blood is getting pushed in, so is the calcium gluconate. And the calcium gluconate, it's a very standard dose, or bag, excuse me, it's a liter bag. And how you run it, they kind of look at labs, and again, they pick a number that they want to start off with. Sometimes it's 40, 50, whatever. It's a very simple number. It's just in cc's. You don't have to worry about like how many, MEQs or whatever. You don't have to worry about that. It's the cc's per hour. And what they'll do is they'll say, all right, we're going to start it off. After you initiate the system, we like to see an ionized calcium within 2 hours just to see if you've dramatically dropped their calcium that's ready to go, okay? Or are you fine? Or are you too high? We don't know. So we start it off, they pick a number. So let's say in this case it's 50 cc's per hour. And then in 2 hours you send off your iCal, and it comes back and it says, 1.23. Okay, that's your calcium, your ionized calcium. You'll see this order be, if this, then that. Very simple. So if your ionized calcium is here to here, you go up by 5 mLs or 5 cc's. If it's here to here, you don't do anything, no change. And if you go here to here, you go down by 5 cc's. So really simple. So, 1 hour you might be 50, and then the next hour you could be 45. Maybe you're at 45 for like an entire day because it's just rocking. So the calcium gluconate is used to really offset what's happening in their body, not the machine, right? I want all of the calcium sort of bound up when it goes into the machine so it doesn't clot it off. But then when it's coming back to the body, if I don't do something about it, all of that citrate might be, starting to suck up all the calcium that's in their body. Eventually they would die, right? So I don't want that to happen, of course, right? So this is a way to sort of offset all of that. So calcium gluconate in presence of citrate will, and administered in this fashion, will offset that. So then in the patient that you guys have in your unit currently, you're not using bicarb. Well, why? Because you have to think about this. Sorry, I said you're using bicarb. Sorry, I am a little off today. I apologize. And please, if I say things like that didn't make sense, catch me on it. My brain is a little bit off. But anyways, the citrate is metabolized by the liver. And so think about the citrate being metabolized by the liver as cracking open now your egg and re-releasing the calcium. Again, it was never gone. It was just stored away. And so when it makes its way to the liver, if the liver is working and functioning properly, then as you're administering this calcium gluconate over here, you're keeping the level sort of normal as some of it is bound. And then eventually that cracks open egg, releases this, and it's nice, this sort of like system, right? Around and around she goes. But if you don't have a liver that's functioning properly, And I don't mean like, oh, I had a little bit of a shock liver, a little bit of rise in my AST, ALT. These are people that have significant, liver damage and liver failure. Maybe their bilirubin is sky high. I know that your gentleman had some sort of, I don't know if it was a lobectomy or something. I just remember he has a bad liver, like a significantly bad liver. And I know his eyes are neon yellow and he looks like a Sharpie. So in that case, nephrology will make the case be say, all right, the citrate is not going to work for that patient. It's too much for their liver to handle. So eventually you put all the citrate in there, and normally the liver would crack open these eggs, but it can't really do it efficiently or well or at all. So it's kind of like as if I never had calcium gluconate in the first place. All of it would start being bound up. It's too much for the liver. We're not going to do it. So instead, we use bicarb. Now think about this. The citrate, the PBP right here, so this guy right here, if I were to inject calcium into that bag, it would immediately get bound up. So we don't do that, right? We put the calcium over here so that it can go into the patient. In bicarb, there is no citrate. It's not an anticoagulant. So technically we could actually put the calcium in the bicarb, but we don't. And the reason for that is that we want to take out one point of human error. Because if they were making it and thought, oh, I'm doing calcium, but really they were actually doing, they were doing bicarb, but really they're doing the citrate, and they were like, oh, I forgot to inject it into the bag, then oopsie, we didn't give them any calcium. So instead of making that mistake at all at any given point, we just always put, I'm trying to find this, we always put our calcium, no matter which product we use, at the end. So then the next question is, well, if you're not using citrate, why do you need calcium gluconate if it's just bicarb? Because you still drag out calcium. You're still dialyzing this, right? You're still drawing it out. So if you just let the CVVH machine spin with bicarb and no citrate at the end, I'm sorry, I said citrate, I meant calcium, excuse me, no calcium at the end, then eventually calcium levels will get lower and lower and lower and lower and lower. So we're still offsetting that whole process, but for just a bit of a different reason, right? In the citrate model, we have dragging of calcium out, plus we have it bound. So it's kind of like two things happening at once that are causing your ionized calcium levels to drop. So calcium gluconate offsets that. But in the bicarb model, I'm just dragging calcium out. I'm not binding it. So I'm still going to have a drop. So therefore, I still need to replace it. But we just always want to do it on a pump. That way we never make the mistake of, oops, it was that product versus this one. Oops, we forgot to inject it into that bag when it was this bag. Like, no, we're not doing that. So another safety method that we can do to protect our patients. All right. Does that make sense? Does anybody have any questions so far? It's a lot of stuff. No, I guess. So again, the ionized calcium starts to get bound up. So if does anybody need me to leave this up for a second? Could you actually tell me that? Just because I wanted to draw something new, I just don't want to clear it if people are taking any notes. How about that neurocritical care group? You all good for a minute?
Mark, hey Mark, I just want to, sometimes when people are, I just learned this the other day from one of the dialysis nurses, if you're getting a lot of, especially with the IJ catheters, if you look at them, they're supposed to be curved. Like if they come out of the IJ, they're supposed to be curved, and they're designed like that. So you shouldn't try and like straighten them out, or sometimes the docs even put them in backwards. So if you're having a lot of like access and return alarms, that's also a good place to check to make sure that that catheter is in fact curved like it's supposed to be.
Yep. No, that's a good point. And, you treat the catheter like I mean, it is a central access point. Just FYI, just a side note is you never really want to use a dialysis catheter if you aren't using it for actual dialysis. In an emergency, use it. You know, if someone's dying, use it, right? But don't just use it as, oh, I got to give some famotidine, so I'm going to use that, okay? Because also you have to remember that the lumens are packed with either heparin or citrate, depending on if they have an allergy or suspected allergy to heparin. Might be packed with citrate so that the lumens don't clot off. So if you're ever to actually use it for real in an emergency in the right scenario, you would want to draw up that lumen to get blood first, then flush it, then do whatever you need to do with it, whether it's, you know, give epinephrine through it or something like that. Also keeping in mind that it's usually doesn't have a clave on it. It has a clamp, so that don't forget to ever clamp it when you're done administering it, because the patient could get an air embolism through that system. So don't use it, but unless you absolutely have to in an emergency. But what I want to point out is that the dressings are done either by people who can do sterile dressings, the central line dressings, so it's PICC, or people who are, you know, checked off in the units. So bringing it to Brittany's point is that if it was a little off, you know, someone who can change the dressing, maybe you can take that dressing down, kind of shift it a little bit, and then redress it appropriately with the chlorhexidine and sterile process and the wands and all of that stuff. So that's a good point, but just keep in mind, don't use it if you don't have to. But if you're getting flow errors, so you have a couple of things. I'm gonna clear this for a second. So you have the access, and then you have let's see, effluent. Then you have filter and return. So this is, you know, drawing blood. Let's see, if this was my patient. This thing is so hard to use sometimes. Getting better, slowly but surely. So access is towards the machine. The effluent is the P, right? So it's after it gets through the filter. This was the filter. On the back side, there's a yellow tubing. So if I was to draw the back side, you would see yellow tubing going down to that big old PB bag that we said on the first scale, okay? The filter is how much actual pressure is in here, and there's these little like pods that you'll see, not the cogs I was talking about, but pods, and they measure pressure. And this one down here is saying, okay, the pressure here in this machine is getting higher. So that's what this one is. This is referring to this, which is coming from that. And then the return is the pressure going back to the patient as it's trying to push the blood forward. So when we look at the machine that I drew earlier, the big one here is the blood pump, which is usually a preset 150, again, mLs per hour, okay? So you have your filter, and we have two things. We have something called a TMP, and we have, oh my gosh, pressure drop, or drop pressure. Both of these things are referring to what is happening in this filter here. Okay, and again, we're looking at the pod. So if we kind of look at this one, I guess, look at that pod. This pod is saying the pressure within that filter is rising. The transmembrane pressure is, oh my gosh, I'm really struggling, is clogging, and this is clotting. So when these numbers go up, it's going to make your filter pressure go up. But your filter pressure is going up, which is this guy here, right? So this pressure here is starting to increase. But these two are telling you why that pressure is going up. So when you have somebody that first initiates CVVH, they've been septic, they probably have cellular injuries, hypoperfusion, so there's debris, there's ATN, whatever these processes are going on. You have cytokines swimming around, doing all this inflammatory stuff. So the transmembrane pressure is referring to clogging. So as these things go through that filter and get swept out, it's just like a vacuum, a HEPA filter, right? It's going to catch all that stuff. That's what you want it to do. You don't want it to be nice and pristine. It's nice when you first do it, right? But as the blood goes through, it's catching all that crap and taking it out of the blood, exactly what we were trying to do in the first place. So what the transmembrane pressure is telling you is as it rises, it's clogging. The pressure, or the drop pressure, or pressure drop as is written on the screen, is saying that, the filter, the pressure is going up. But in this instance, it's not because it's catching a lot of stuff, although it might be, but it's actually clotting off. So it's like no matter what, the end product is filter is going to be going down because the pressures are rising, but telling you why it's rising. So is it clogging or clotting? One or the other. And in some instances, going back, and we can use the patient that's in that room, which room number I can't remember, but the corner room in the neurocritical care side, is the patient can't have citrate, so that means the system is not being anticoagulated. I don't know the reason, but the patient can't have heparin. I don't know if it's because he's so at risk of bleeding already because his liver's in failure and he can't clot himself. Doesn't mean he can't make a clot, but he just can't clot well because his liver's injured. So the clotting factors aren't being synthesized well. So the risk of bleeding is already significant. So sometimes what you can do is if you can't anticoagulate your system with citrate and you got to use the bicarb, then can we use a systemic heparin drip to sort of keep the machine nice and patent? Because now we're anticoagulating the patient. So therefore his blood should already be anticoagulated. In some instances, like this guy, he can't have either. He can't have citrate, he can't have heparin. So now you're at the mercy of, hopefully he does not clot this thing that fast. And one method that we can do to sort of try to get some longevity out of your machine, out of your filter, is to flush it. So you'll always notice that the way they set up this, this whole machine, one of the features is on the red port from the Prisma machine. So this is Prisma and this is the catheter. Okay, so this would be, let's say red is red and red. Then right here, gosh, right here we have a stopcock. That is my stopcock. That is a three-way stopcock, believe it or not, okay? And this is the flush system. So you see this just one saline bag hanging out on just a straight tubing with just a roller clamp and a couple of green clamps. And normally the stopcock is upwards, meaning blood or something can't run in that direction, right? So that means blood is coming out of your patient and running through it and going to the machine. But if I need to flush the system, whether it's to flush for this conversation we're having right now, or you want to return the blood or whatever, then what I can do is take the stopcock and I can turn it in this direction, which means now it's facing this way, so nothing can come from this direction, but now it's open this way, so now the fluid bag that's up here, it's allowing it to suck the volume of saline, remember, saline, no calcium. And usually, you know, if it's just to cleanse the filter in this scenario where you can't heparinize, you can't use citrate, usually about 100 cc's is sufficient to really kind of wipe that filter through. So what you'll see is that there's no like magic thing on the screen. You basically just run up there, turn the stopcock over to the patient. Before you do, just a side note, make sure you unclamp the green. Some people get super clamp happy. They roller clamp and they take all the green ones and they clamp those. Just the roller clamp is good. I mean, if you did all of them, no big deal. Just remember that right before you want to turn your stopcock, open everything back up and then turn your stopcock off to the patient, meaning in this direction, allowing the machine to now drag the fluid through. And what you do is you just stare at your saline bag and just watch it drop and just look at to see about 100 cc's goes through. And what you'll see is that all the blood starts, this whole system going to the machine starts to look like really diluted Kool-Aid. which is because now you've just stopped all the blood and you're wiping through all the blood cells with this big old line of saline. Eventually, you'll start cleaning this, and we'll get to the filter. And what's really nice about that timing when you actually clean it, you can look and you might see a lot of this purple striation just going up, and that's clot in those little tiny, like little tiny straws, those little capillary type straws, which are the filter straws, right? So you'll see it, and you can look, sometimes from the side, you can just see it, the striations just going up and up and up like this in the cylinder like that. Or if you were to look top down, you're going to see these big old dark spots like everywhere, sometimes a big old group of them. And you're seeing that that's actually clot, not clog, clot. And that's, you're going to see it reflected in your clotting, your drop pressure, okay? So in the instance where you can't heparinize, you can't use your citrate, then you're left at the mercy of hopefully this doesn't clot. And usually about every 4 hours, they're going to ask you, and it's part of your orders, would be to just flush the system. But remember, every time you flush the system, if you're not doing any fluid removal on your patient, you are now giving them 100 cc bolus. So every 4 hours, you're giving them 100 cc's, 100 cc's, 100 cc's. So if we do that over a day, that's 600 extra cc's that the patient's seeing. And we're trying to, sometimes we're either just trying to scrub their, blood, or now we're trying to actually remove it. So now you're actually adding that back, right? But it's hopefully keeping the filter system running longer than maybe it would have if you didn't do it. So it's just one method. You do have to open the system up and do that when you want to return blood. So if we're done with the machine, or dialysis nurses are going to come in and they're going to actually change up your setup. So take this filter down. And if the filter has made it, which is great, but 3 days is the cutoff. That's when they're going to actually change it no matter what. So in any instance where you're going to have to take the machine down, you need to flush the blood in. The only time you can't do that is if now there's air after the air chamber side of things. So that's the return line going in. If air makes its way there, you're done, which means you disconnect everything and they lose all of the blood that's in the tubing as well as the filter, which can be significant for some patients. Some patients won't tolerate that. Some other patients say, whatever. It's like a few hundred blood draws that we do in a day, right? So they're not too rattled by that if you take all that blood. So that's the TMP, that's the drop pressure. So clogging versus clotting. The filter pressure will be rising no matter what in either instance. Sometimes you might see a combination of both. The TMP is rising. So, 100s to 200s here, those are normal ranges. When you get to like your 300s, that's fine. That just means, all right, it's getting to the end of its lifespan. It will still run. Just notice at the top of the machine you have a light. Green, yellow, and red. Green is good. Yellow is like, hey, look at me. Something's not great here, and it could be a lot of things. It's not just a TMP. It could be a lot of things. Some of the pressures, it's like, all right, you're in a range, you're okay, but it's going to be getting worse. So I'm going to just keep a yellow light on and just let you know, like, something's up. Everything's still good. Patient's not going to die. Nothing's, disconnected or whatever. But pay attention, sort me out, figure me out, but I'm going to keep going. I'm going to keep doing my job. Red, hard no. We're done. Lock out. So if you get like a dramatic pressure drop, so let's say you are turning, this is a common one, probably the most common one, is, you have these catheters, and like Brittany was saying earlier, they're very positional. Sometimes you have those two holes that I was drawing earlier. Maybe one got, butted up against the vessel wall when you turned them. Sometimes it's in their groin, and, you turn them this way and their legs are kind of close together. And then all of a sudden it's like, the sucking pressure from the access point was like, okay, now you turn them and their pressure's like this, and it's like, ugh, it really can't suck anymore. It's a dramatic change, so it's going to be like, boom, lockout, stop, go figure me out now. Okay, so just remember that. Red, nothing is happening. In green and yellow, this blood pump over here is always going. It's always moving. So even if you're red and you had to stop for something, so let's say it was just simply changing of a bag, or your TMP is high but not super high, you'll see that the blood pump is always going to be moving, which means blood's not stagnant, less of a chance to clot, right? But just remember, sometimes those cogs might not be moving in certain scenarios, like when you're changing bags. In a red error, so whatever your red alarm is, nothing is moving. This blood pump isn't moving, none of the cogs are moving, and blood is not moving, not going anywhere at all. So the chance for the clot to form, right? So we don't want that, of course. So you always want to respond to your alarms, but just remember, red is a hard no. So something like the pressure issues, this is a really common one. So you turn your patient, maybe it's in the femoral vein, and you move your patient and their legs are too close together, and you get this dramatic change in an access or even a return. So it's trying to force it in, and now the pressure's too hard, too resistant to push it forward. Your change in pressure is going to be like boom, it's going to make that machine go into lockdown mode and clamp. And then what you're like, oh, and it will say return pressure too high or access pressure too high. All you have to do is take their leg and maybe move it out to the side. Maybe it's up here. Maybe you have to just turn their neck after you moved them, because when it's straight or too far this way, it's kind of kinking the catheter, and so you want to move it back this way or something like that. So you just sort of have to troubleshoot. So it's okay. Don't worry. Like the patient's not dead. You're good. Just take a second to figure it out. What did you just do? Or what might have just happened? Maybe your patient woke up a little bit, a little restless, and they kind of wiggled all over the bed, and now their legs are too, close together, and that catheter is not happy. So that makes the machine have to work either harder to either draw or push back. Sometimes it's none of those scenarios, and this is where switching of the lumens. So sometimes maybe your catheter, maybe it's not that it's, clotting off inside the catheter, but maybe it's just like, this is butting up against that vessel. So sometimes you want to draw from the red port, but it's really hard. But when you draw from the blue port, it's like super silky smooth. And then when you try to push in the red, it's like silky smooth. So that's when you reverse the lines. And as the bedside nurse, I don't recommend this to people who are brand new to the machine, of course. But as the bedside nurse trying to troubleshoot it, you can do that. Just make a little note in the CRRT flow sheet, but you can do that. You're allowed to swap those lumens, and there's a nice easy way to do it. You just have to make sure you stop the machine, not shut it off or anything, but stop it, and then clamp this, clamp this, clamp that. You're doing all these clamps, and you're reversing the lines, and then you're opening it back up, undoing all the clamps, and hopefully hitting start. And all of a sudden, it's like, oh, so much easier to suck now. Oh, so much easier to return. And that's okay. Just know that you've dropped a little bit in your efficiency on cleaning blood, but that's no problem. That's not a big deal. That's all that's happened. But now your machine is up and running, and you're still cleaning blood, and you're still anticoagulating if you're using citrate. Like all of those things are still happening. So that is okay. So going back to that flush system, just remember every time you do it, you've introduced another fluid bolus into that patient. So when I return blood, I always do about 200 cc's. I know the filter's 1, but I find that 200 cc's really, in my mind, gets most of their red blood cells back into them. I mean, you're still going to have some Kool-Aid looking remnant, but you get most of that in. And then there's it's hard to kind of say it, but there's this very methodical way of returning blood if you ever had to. And it's slow, but methodical. And I recommend people who are new to it that you do it with somebody that knows how to do it, but you do it through that method so you can see how the machine is working, what to clamp, and it walks you through it. It's very easy. I personally have a shortcut, which is you return the blood while it's running, because you just turn it off to the saline, off to them and open to the saline bag, and when 200 cc's goes through, you just stop the machine. You're already done. The moment you are done with your machine, the machine, like everything from the machine side does not matter. I don't care if you take the tubing off and oopsie dropped it on the floor. It doesn't matter because you're done with it. The thing you want to do is make sure you are protecting those catheters. So first things first is that the moment you are done and you do any sort of disconnection, you do need to prepare and know if you're going to pack your lumens with either a heparin, which is 1,000 to 1, or a citrate. So maybe they either have HIT or maybe you're working them up for HIT. So I don't want heparin sitting in their catheter because, oopsie, that could be potentiating that if that was a problem for them. So that's when you have citrate. So the heparin, it's easy. We stock it, you draw it up, and you pack your lumen. The citrate, the pharmacy has. I will say cheat if it's during the daytime, Monday through Saturday. You can call up to the dialysis unit, and usually they have a few syringes, and there's always 2. You want 2 because you're going to pack 2 lumen, right? The red and the blue. And depending on where they're actually located within the body, the lumens are different sizes. So the femoral one, a lot longer. The right side is the shortest one, then this one is the next longest, and then this one's the really long one. And so they're going to be different fills for those ports. So when you look at the side of each of the catheters where they clamp, it will say 1.9 or 1.6, 1.8, whatever. That's telling you that's how many cc's it takes to pack it. So I always overshoot, so that you'll see like the citrate syringes are always pre-filled to 2 cc's because none of them are past 2 cc's. I usually take and draw all of my heparins up on 3 ml syringes and put 2 cc's in there, flick out any air, and then when I'm ready to pack it, I'll look and say, okay, this one's 1.8, so I'll look at it and squish it out to 1.8. Now, that's having everything prepared. So when the Prisma machine is done and you hit stop, again, you're about to junk that system. So I don't care about sterility to the machine side of things. So if you I don't have a red cap right now and you just want to drop it in their bed when you disconnect it, and I'm talking about the tubing from the Prisma thing, not their lumen. You want to keep that thing as sterile as possible, okay? But on the lumen side, I want to take a saline syringe, and I immediately want to just flush that system so that hopefully there's no blood. And I do it aggressively. I want to pulse it a little bit and force it in. And I clamp and I leave that syringe on. I just leave it there. Then I go to the next catheter. So now if I did the red, now I'm on the blue. Take the blue side of things, disconnect it, throw the Prisma tubing on the wall. Don't do that, but throw it over there. Who cares? I usually red cap everything so blood isn't going anywhere. But I don't care about it. What I care about is just now the catheter itself. That's who you need to protect. That's your baby. So now I want to flush the blue side. And blue, red first, it doesn't matter, but flush whichever is the next one. Flush that so that you get all the blood swept out of that catheter. Now, and clamp it. Now that I have the 2, whether they're citrate syringes or 2 heparin syringes, I'm going to squirt out whatever, have the right dose based on what the lumen tells me on the clamp, and I'm going to take off the flush. I'm going to put on the heparin or the citrate. I'm going to open up the clamp, and I'm just going to push it all the way down. I'm not going to be like, but just going to push it all the way down. And I have now packed that lumen. I clamp it, and I am done protecting that. The last thing I'm going to do is in the clean utility rooms, there are these chlorhexidine. So instead of putting a red cap at the end of each of the lumen, they have these little chlorhexidine type caps. And that's what they want us to use. So if you ever have to return blood, you would want to open this little sort of foilish package, and there's 2, and you just put them in and you screw them on, and that's what protects the outside, and you're done. So you do both lumen. After you have protected that lumen and packed it and done all of that, now you can go start working on your machine and junking stuff and taking all the bags off and putting them in the sink or whatever, wherever you have to put everything, and then taking the machine down, But you, as soon as you're done with this machine, we don't care about the machine side of things. We only care about the lumen side of things, the catheter, because that's what needs to stay working, right? Good conversation. Anybody have any questions about this so far? So I'm just making sure I don't miss anybody. I'm just going to take a quick peek at my phone. I know some people have been texting me, so I just want to make sure I'm not missing. Nope, okay. So again, just talking about the access and the return, you're going to see negative numbers because it's dragging and pulling. So when you document on the CRRT flow sheet, you're going to see a negative number, and you write them in order. So if it's like negative 128, when you go into your flow sheet to chart that, you want to put negative 128. It's actually funny because this actually happened the other day. When it comes to the fluid removal, I'm just gonna clear all this for a second. So patient fluid removal equals UF. This is ultrafiltrate. It's the same. It's just fancy talk for taking the water content out of them, right? So the fluid. So when we introduce the patient to CVVH, usually we don't take any fluid off. We just want to make sure they can tolerate it. So what they are getting is they're getting their blood scrubbed, which is great. That's what you want to do. But we are not taking any fluid off yet. Then, they start tolerating it, and they're like, all right, let's give it a go. Let's take off 50 cc's an hour. So you go over, and there's this patient fluid removal, and we might say, oh, they're being UF'd at, or let's set the UF at, blah, blah, blah. So this is the same thing, but on the Prisma machine, you're going to see patient fluid removal, okay? So you start taking off 50 cc's. Oh my gosh. So if you go back to what I said earlier about the 3,000 in an hour plus the 300, now you have 50. So now at the end of the hour, you should have 3,300 and now 50 cc's at the top of an hour. When you look at the history screen after the hour has elapsed on the CVVH machine, they're not quite timed like your clock is. They also don't account for daylight savings time, so sometimes it's actually 8 o'clock and this thing is saying 9 o'clock. Don't worry about that. Just take it for the hour you're in. So once it elapsed for the hour that you're within, then you're going to look at the history button, and the history is going to tell you actually how much the machine took off. So you have to remember that if the machine has 0 interruptions within 1 hour, then I should have all of this happening, and especially the fluid removal. But every time there's an interruption, which means, hey, your PBP is done, so now we're going to hang a new bag, and it took you a minute and a half to do that. Well, that's a minute and a half that you weren't doing treatment. If you are eating lunch and socializing and didn't hear your bell going off, and for 5 minutes it's saying that your effluent bag was full, that's 5 minutes that the machine wasn't running. The blood pump is, but those 4 cogs are not, right? So blood is still being circulated because it's a yellow alarm, but nothing's happening. So blood is just moving around and around and around. So at the end of the hour, when you go to the status, you might see that it only took off 38 cc's. Wait, I set it to 50. Well, that's because you had so many interruptions. So therefore, this is what it did within that 1 hour. So that's why you really want to be as prompt as possible anytime you have CVVH, because you really want to pay attention to your alarms and acknowledge them and treat them very quickly. So, when you are turning your patient and a red alarm goes off because their leg was too close and it just kinked the catheter, and all you have to do is pop it back open, or their legs back open, and it makes the pressure drop, and then you can hit the continue button. That's however long that whole process took is treatment that never happened. So that's why things don't always add up in the end. But what you're going to see, I just want to make note of this. So it's okay. All of those things are okay. That's how this whole process works. Don't worry about it. But just make sure you stay on top of your alarms. Don't just let them beep off for an hour. But you're going to see that the patient fluid removal was 38. But sometimes you're going to see a negative number. You're going to see negative 12 in the patient fluid removal. It's the opposite. If it was negative, that means it gave back fluid to the patient. Sometimes that happens. Sometimes it might account for, I took off just a smidge, so you set it to 50 and it took off 60 this hour for whatever reason, because this thing isn't to a pinpoint perfect. So it might say it took off 60 1 hour, so maybe it gave back 8 cc's. So you'll see actually a negative number in the output, which means it gave back fluid, not took off more, right? So it's kind of maybe compensating. And you'll see this, and it will never be exact, and that's okay. You just want it to be very close to the number that you've chosen, right? So if it's 50, 55, 39, then it's maybe 60, maybe then it's 50 1 hour, and then it's, negative 12 because it took off too much that previous hour. It's okay, but you just don't want, like, if you see something, and I'll just talk about the instance when we set up CVVH on the weekend for that gentleman on Sunday, excuse me. When we first set it up, that first hour, it said negative 74. So it had given him 74 cc's. And I was like, that's a lot. That's a lot of fluid for somebody that we're UFing, or fluid removal rate, 0. Because this is the first time we've set up 0. So nothing should have been taken off. But it's doing a lot of things and adjusting and trying to figure itself out. So that first hour, it kind of gave a little bit of fluid. After that, it was right on par. It kind of wobbled back and forth. 1 hour it was like negative 10, so which means it actually took off 10, and then it gave back, and it kind of just stayed kind of really close and fluctuated with that. And again, it all is sort of banking on how many interruptions it has within 1 hour and trying to sort of compensate for those interruptions. So that's therapy taken away from the patient if it's not running. Just things to think about. And then when it comes to how those bags work at the bottom, they're all a scale. So if you've never grabbed them or touched them, each one of them, you pull them out. So they literally just kind of slide out on this little bar system. And so, you have all these bags, you change them as they need to be, and then you push them in and you make sure they click, and they're all color and symbol coded. So it's like yellow circle and white triangle and green square and purple stop sign is how I like to call it. So let's be real, a kindergartner, if they learn their shapes and colors, could change the bags because it's color coded. It doesn't tell you what the bag is anymore like it used to. It's trying to make it more simple, user friendly. So if you forget what the word effluent meant, you don't have to worry about it because it's the yellow circle. So you hang yellow circle. What's on the yellow circle? Effluent bag. So the first one is different than the next three. And what I mean by that is when we talked about the bags on the scales, right? On the bottom of the Prisma, we had effluent, we had PBP, we had saline, and we had saline. These ones run out of fluid. This one increases fluid. So the scale is set to a weight, which means if this one reaches a certain weight, ding, 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 the machine will tell you, it will stop the yellow, you'll get a yellow alarm, so blood pump is still moving, but you will get the yellow alarm, and it's saying the weight of this hit this number, therefore change me. These ones drop, right? Your fluid is being removed from it, being sucked up into the system, so these all get to a certain low weight, which is a safe weight, meaning, you might have like 100 cc's in these saline bags, and you might have, 150 cc's left over in the PBP bag, and it's a safe weight, so you'll always have volume. You will never suck these bags dry. So once the scale is sensing that the weight got down to a certain point, it says, all right, change me now. And I won't run until, so you can't fake it out and be like, all right, well, there's like in our IVs, they're like, there's a little bit like 25 more in the Vanco, I'm going to add like 10 more. You can't do that with this. It's if it hits that weight, game over, you're done. So this one, let's just talk really quickly about this one, because this is the one that scares a lot of people, because sometimes pharmacy, I'm not knocking pharmacy, but sometimes they are late. They have to make these bags, and depending on who the runner is, some of them are amazing. They always swing by time to time and they like eyeball, okay, you got like 3 more on the table. Okay, I think I'll wait an hour and then I'll put another 4 through for you. But every time you hang a bag, at least, if it's good if you have 2 on the table. What I mean is like they haven't been used. You have 1 physically hanging, running, the machine is running. But you have 2 on the table. If you get down to just 1 on the table, you hung this, so no more. Sorry, I don't know why I just drew that, but whatever. So you're done with this one, and now this is the last one on your table. You need to call the pharmacy, the runner, whomever, and you need to say, hey, I need 4 more or 6 more, depending on how fast you're running and how many that you usually are getting, right? Because it takes them a while to make it. So just as a very great technique, if you forget, or maybe you didn't forget and they're just super late, there's issues, whatever, and you are literally, there are no bags left, and you are on this last bag, and you have, you know, on your screen it will say like next intervention. It will say like 5 minutes, which is great. It tells you exactly when you're going to have your next thing due and what it is, because it's weight based, right? So it says in 5 minutes your PBP is going to be done, and I don't have another bag, and they're telling me it's going to be at least a half an hour before I get it. Well, half an hour and these 5 minutes. If those 5 minutes elapse, you have nothing to run anymore. That machine is not working. It's just going to circulate the blood. The blood pump is going to be moving round and round. So there's one method to cheat this system to keep everything running. And that is to go into your screen, right? And you get these values, and then you get your pressures, and then you get this screen here, kind of like here, and it will say like info and TMP. This info tab is where you get this information, which is great. I mean, you could literally be like, hey, 45 minutes, I'm gonna go get lunch or something. Unless the patient moves for a different reason, something sets it off, I should have 45 minutes before this thing yells at me to have anything done to it. So in this case, it's saying I have 5 minutes. So there's this, what is the word? I forget the word, it starts with an A here. Anyways, you press this and you get a screen, and it's telling you, here's your PBP, here's your patient fluid removal, and it's got all these little icons. And what basically you say PBP, which is running at 2,500, 3,000, whatever, and you go and select it. So you say PBP, and it highlights the PBP numbers, and then there's an up and a down arrow, and you just hit down, down, down until there's like, I think it stops at 50 or 30 or something like that. That means now you turned it from 2,500 or 3,000 into 30. So now you took 5 minutes and probably turned it into 10 hours. And that's how you keep the whole system running for this temporary time of, hey, we'll get you your bag in 30 minutes. I swear, I'll give you my firstborn if I don't. And you buy yourself time. Then when you get your new product, you turn the PBP, don't forget, you turn your PBP way back up to its 25 or 3,000 or whatever number we were using, and you're back on track. This is how to buy yourself time. This is tricks of the trade, okay? Always a good one to keep in the back of your, back of your head or in your pocket, because this could happen, and it does happen. So try to be on top of ordering it. When you know, like, I get a bag an hour and I have 4 hours, then usually when I'm down to the last 2 bags, I'm trying to call for the next 4. If in the patient that was in the corner, he was on a bicarb bag, which is not 3,000, it's 5,000, which means he had a rate of 2,500. So every bag was about 2 hours. So he had a long time with each bag. But usually if it's citrate, it's always a 3,000 cc bag, which means if you run it at 3,000, that's a bag an hour. So, if I got 2 bags on the table, that's 2 hours. So it runs faster. And then just a side note, when you look at, so the machine itself does not have a battery. So it always needs to be plugged into the red outlets or the glowing outlets, so that if, in case of a failure, that you do have power backup, okay? I don't know why that was not included in the model. It seems to me like that would make sense, but it doesn't. So in case of a power failure, and it's not because, it's just power failure, so the machine stopped running, and it's good blood in that system, and there's no air and all that stuff, it's not clotted off. You'll see in the back there is this like really interesting tool. It's a little whatever you call it. I'm not thinking of words today, or really ever, but you take this tool, and it's got this hexagon shape on it, on here. And you'll notice, remember I was drawing the Prisma machine, and I was like, here's your blood pump, and then you have your 4 cogs, and then your filter. This little spot right here is a hole that has a very, very perfect matching hexagon. So what you would do is, okay, I can't run it. The power went off and the machine is down. And you can't just turn it back on and like resume where you were. Done. So what you can do is take, as if you were returning blood while it was running, you could turn the axis off to the patient, so no more flow from patient towards the machine. Turn it open to the saline bag, make sure you unclamp it, and now you are the machine. You stick it in there and you turn, and you and it pulls the blood just as if the machine was actually running. And you just look, like I said before, you take 100, I like 200 cc's, and you're returning all of those blood cells back into the patient. And then just like we said before, when you're done, now you're protecting those 2 catheter lumen, right? I don't care about the machine side of things anymore. I am done. I can throw them on the floor. I don't care. I want to cleanse each catheter port with saline and then pack it with whatever the appropriate thing is, whether it's the heparin or the citrate, and then cap it with those chlorhexidine little caps. So little thing to kind of keep in mind. And I haven't had to do this myself personally, but I know this has had to happen a couple of times. And sometimes it might not even be a failure on power. It might just be a failure on the software on the machine. Not that that's typical, but that it's a possibility. So anytime you have your patient, you get a big old order set. So now we're going to talk about some labs, right? So you get a big old order set. And before the labs, I just want to point out you have usually a patient fluid removal rate of 0 to start, and then the nephrologist, the fellow, whomever, can tell you, let's go up on it, let's go down on it, whatever. And all you do is hit this little button that's kind of like right here on the screen, and then you select, instead of the PVP in this one, you select the patient fluid removal rate, and it highlights this one, and then you go up, down, whatever you need to do, hit confirm, and you're done. All right? So the blood pump is always 150 unless it needs to be changed, but standard is 150. And then when it comes to the PVP, it all depends on which one they want to do, and then what's the volume. So whether it's citrate or bicarb, it would be run at 2,000, 2,500, 3,000, and that's kind of helping to sweep more or less and alter their electrolytes a little differently, whether it goes faster or slower. So now let's talk about those labs. So the standard protocol is that when you initiate the system, again, especially with citrate, you would always want to look at their calcium level about 2 hours after you start. That's kind of new practice. We never did that, to be honest. That's probably in the last, I think, a couple of years now that we started doing that. Before, nephrology would say, all right, you're going to set your calcium gluconate on the end pole on the plum pump at this number, so whether it's 40, 45, 50, whatever, start here, and then always, including now, your orders are Q6, here, I'll write this down. So your iCal is Q6 hours, and then you have BMP, MAG, and FOS, all of them are Q12. So at 1 hour, you're doing one of them, which is this guy, and then 6 hours later, you're doing all 4 of them. So these 3 plus this one, and then 1, and then 4. And so every 6 hours, this is what's happening. And so your iCal, like I said earlier, it's based on the number that you get for your result. And then if it fits in this range, you either stay the same, go up by 5, go down by 5. And if you change it, you would wait 6 hours later, and then you get your next iCal, along with now maybe your BMP, MAG, and FOS. And then based on that number, you either titrate, don't titrate, just depends on where it is in the range. You will see part of that order as being, if you've gone up so many times, right, and now you're at this max dose of, let's say you're at 80 or 70, And it says like, if you are at 70 and you're still down here where it says you should go up by 5, but you've hit the ceiling for them, which is, you know, in this order it might be 70, then it says call nephrologist. Usually what they do is they say either leave it or even maybe go up by 5 more, but let's give them a big dose of calcium gluconate. So they might say, let's give them a couple of grams of calcium gluconate as well as this infusion. And maybe that will bump them up. So now by the next time you do it in 6 hours, they're finally at a nice level, they're cruising along, everything's grand. So iCal and BMP. And just, I meant to talk about this earlier, and I'm sort of like losing my thoughts sometimes, but I just wanted to point out what's so special about this. So I often teach that in the ICU, something called the total calcium, no one gives a shit about total calcium. We shouldn't really care about it. Outpatient setting, sure, it makes sense, right? But I'm just going to use this analogy. So this is albumin. And this is a normal patient. And this is, don't worry about the actual number. This is just me trying to get a point across. All right. So you have ionized calcium, which are these black dots. Okay. This is a normal and this is an abnormal patient. Okay. This albumin, the total calcium is in relationship to albumin. So sometimes it's actually bound to the protein, right? So you have calcium on here. Oops. Calcium, 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 all the way down, right? All of these are calcium. So if I have a nice, healthy patient, eats very well, takes their multivite, whatever, eats a lot of dairy, whatever, this calcium level should be normal because I have a lot of protein, the albumin circulating around, and it's transporting this calcium to different parts of the body to do whatever processes it needs. So let's say all of these are 100% bound. Perfect. Now I have this malnourished patient, alcoholic, maybe somebody who just anorexia, maybe they've just been sick for a while and they just haven't been able to eat, who knows, but they're malnourished. So therefore, they don't have a lot of albumin, they don't have a lot of protein. But the protein that they do have is also 100% bound, right? Well, the relationship looks terrible, right? I still have enough like perfectly bound calcium to their protein, that albumin, but I don't have a lot of albumin. Had I had a lot of albumin, I'd probably have a better total calcium. So there's this thing called a corrected calcium equation that's based on hypoalbuminemia. I don't know it off the top of my head. It's one that I usually have to Google, but if you just go in here while I'm lecturing, if you want to, or some other time, or never, it doesn't matter, but you type in corrected calcium equation for albumin, and you get like all these websites, and basically you plug in numbers. You just have to be careful. Some places measure it grams per deciliter, and others, like I forget if it's milligrams or something different. It's just make sure when you're plugging in numbers, it gives you options for how your institution is providing that information. So if it is a gram per deciliter, then you want to just make sure the drop-down menu in these different equations match how you are getting that information. So if it's grams per deciliter, you would just make sure your drop down is grams per deciliter. Then you plug in the numbers of here's your albumin, here's your calcium, and then here's the targeted number that would be normal in your institution. So then you plug that number in and you hit enter, and bam, it will say here is your corrected calcium had this been a normal albumin level. So there's an equation for this to say, oh, it looks scary at 6.2, but when I do the corrected albumin equation, it's actually 8.2. It's fine, or 7 point whatever. That's probably an extreme of an example. But my point is that I don't care. I want to make sure they get better albumin, so because they're malnourished, so we got to fix that. But I don't care about that. I want to know who can do their job right now, not later, now. iCal, ready to go, ready to do their job, go in that cardiac muscle, the smooth muscle, do whatever it needs to do to make vascular tone and a heartbeat and conduction and all that stuff. That's what's important, and that's what we want to look for, and that's why we don't look at total calciums, we look at ionized calciums. So that's why, like, whether it's giving blood from, massive transfusion or just a few units from an operation or whatever, we're using citrate to bind ionized calcium, all this extra calcium floating around doing nothing. And if we're doing CVVH, I'm literally giving you citrate into your bloodstream, right, to anticoagulate the system. All of those things are going to take and bind in the Easter egg, right, your calcium. So now I want to hopefully crack it open with my liver. But this is how I want to monitor it. And then that calcium gluconate infusion at the end is what's going to sort of offset that. And just as just a fun tidbit, nerdy tidbit, if you, not that we ever do this, but just to kind of think about the theory here, is that if I had some sort of like continuous monitoring device, let's say I'm running my calcium gluconate at 50 and my iCal while I'm on citrate for my CVVH machine is, my iCal is perfect. I'm like, 120, and it says don't make a change based on that number. And we're cruising along for like a day, looking good, beautiful, right? And then all of a sudden they're like, all right, I think we're going to stop it for today and we're going to try HG tomorrow. Okay, I'm going to go over and return their blood. So what you're going to see is, here we've been cruising along with their ionized calcium, and then I stop the machine and return their blood. And then what you're going to see, what you would see, is this rise, and then eventually fall, and hopefully fall back to normal. Why would I see this? I'd see a rise in my ionized calcium because as I've stopped the machine, I've maintained a normal ionized calcium level with the calcium gluconate infusion. But what I have done now is stop the machine, and as my liver keeps cracking open those eggs, that metaphorical egg, right? I take this egg, crack it open, and I drop out a calcium, and ta-da, here's an extra calcium. So now all of a sudden I have a rise, and then as time goes on, the body's like, I don't need all that. I'm going to put this on an albumin. I'm going to send that over there. I'm going to put this in that bone over there. I'll leave you alone. You're good. I like you. I'm going to keep you going. So then you see that drop back down to hopefully what is normal. Again, we don't monitor for this, but this is what you would see had you been able to monitor for something like that. So the BMP, electrolyte orders are different with this. So you should not have an electrolyte protocol order for this because we do it differently. There is a very odd range for potassium. So there is, if this, then that, a lot of order sets for your potassium and your magnesium. If this, then that. So there's actually a 10 MEQ, believe it or not. So I know we wouldn't normally do that for anybody else, but there is a 10 as part of this one. And this one, I quite can't understand, not that I can't understand the potassium, but I can't understand why they do it this way. But if you have to give 10, if it's from this, if your potassium comes back off your BMP from here to here, and I forget the exact range, if it's like 3.7 or 3.8 to like 4.0, they want you to give 10 MEQs. But you have to order that from the pharmacy. It's not like I take a 20 and give half, which would make the most sense because that's 50 cc's. But they send you 10 in a 100 cc parfil, which I don't understand. But that's how it works. I feel like if I can get a 20 and give you half, why not just give me 10 and 50? But somehow. So that's like, to me, a lot of fluid for something very small. You do give it over 2 hours. Otherwise, if you gave it too quickly, your machine could sweep it up and drag out that bigger volume or that bigger dose of potassium. So you'll see that it says give 10 MEQs for this to this over 2 hours. So do that. Do it over 2 hours. So just keep that in mind. Then you have a 20, and then, there's obviously different range. Mag, same thing. There's a different range, 1 gram versus 2 gram. You do not have an order for phosphorus. You always will have to call for your phosphorus. Now, we know that the kidneys are responsible for excreting your phosphorus, right? So if you have a dialysis patient, you always want to be wary of if they're not peeing, things that have phosphorus in it, so low phosphorus. And if they have, in our world, they have acute kidney injury, you're going to notice that their phosphorus is probably rising, right? Because they can't get rid of it. So when you put them on CVVH, you eventually start dragging that out. So you'll actually go from one extreme usually to the other. So I had a high phosphorus for a while, like 4, 5, 6. Now I'm like 2.0 or 1.5 after like a couple of days. Why? Because it's doing its job. It's taking all that stuff up through the filter. So now, excuse me, I need to replace that the electrolyte phosphorus. I need to replace that. So I will, call whoever it's nephrology. So if I can't get a hold of them, then sometimes it's, your residents themselves being like, can I give this? And just be mindful of what the other labs are, because it's not just looking at this tunnel vision phosphorus. Maybe their potassium is low and their phosphorus is low, and their potassium might be just a little bit low. So I might say, instead of giving him the 10, why don't we give K-phos? And that way I'm kind of two birds, one stone. I'm not going to give them the 10 MEQ Parfil. I'm actually going to give them, maybe it's 30 millimoles because it's very low for their phosphorus. I'm going to give them 30 millimoles. Well, just keep in mind that for every 15 millimoles of K-phos, the K part is 22. So 22, 44, 66. So if this is 15, 30, 45, what is Mark saying? This is K-phos. So if they say, let's give 30 millimoles of K-phos, the K part is 44 MEQs. It's like giving a 40, right? And the 15 of K-phos is 22 MEQs. Now I know sometimes we'll do a 10, sometimes we'll do a 20. You obviously do some math at somewhere in the middle of all of those things. But the point is that those standard numbers are those standard potassiums. And so instead of giving them instead of giving them 10, and I just need to give them a little bit of phosphorus, if I give 15 of K-phos, I'm actually giving them 22 of potassium, not 10. So it's a little extra. And then if their K is high, but their sodium might be low, then I might choose sodium phos. So don't be so tunnel vision. And sometimes you do have to look at that because, again, we're a team. It's not an oversight, but maybe the doctor didn't recognize that. And you're like, ooh, I see you ordered sodium phos, but their sodium is actually 150 and their K is a little low. So could we get that switched to like maybe 15 of K-phos or something? Because I feel like that would work so much better in this scenario. Their sodium is already high. I don't want to add fuel to that fire, and we are going to replace the potassium anyways. Here you go, right? So just kind of be mindful of that. And then we think about the relationship with potassium and, not potassium, phosphorus and calcium. So I got to tell you a funny story, but sometimes it's embarrassing to say it, but you got to learn, right? You got to stumble to keep on going. And so for a long time, and probably at least a good year, if not way longer, could even be 2, I don't know. I used to, as a brand new nurse in the ICU, back then I remember seeing, and you still see this today, I just haven't come across as many patients, but keep note, if you have a patient that is a renal patient, especially if they're pre-existing, and they order calcium carbonate, aka the Tums, right? And they'll order Tums 3 times a day. And I remember what the hell are these Tums? And they're scheduled, they're not PRNs, they're scheduled Tums 3 times a day. And sometimes, it'd be like, the patient's intubated, they're not eating, or they got 2 feet, not given, right? Or I'd walk up to a patient that was awake and talking and be like, hey, are you having an upset stomach or indigestion? No. Okay, well, I'm not going to give this. I'd be like, hey, to the resident, could you switch that order to a PRN? I don't know why we're scheduling this. No one told me this. I learned it myself. It was one of those things where, you're standing in rounds and you hear a nephrologist talk and then you're like, oh my God, what the hell? This whole time? This whole time. Well, you have a balancing act of your calcium and phosphorus, right? Each one of these balances each other up. And so what will happen, calcium will bind to phosphorus, aka phosphate binders, I didn't realize this back in the day, that these will bind, keeping the level normal within the bloodstream. So this is a parathyroid hormone. And it's oh gosh, I'm losing the words. It will come to me. Anyways, it will come. The word I'm looking for. But Feedback loop. That's what I'm trying. Feedback loop. That's what I'm trying to think of. Okay, so what will happen is, if your kidneys don't work and your phosphorus levels keep building up and up, well, eventually there might not be as much calcium present to offset this. So if I have the 2, and now I add 4 more, and this is all I kind of had in my bloodstream, and then this binds to this and binds to this, then it's like, wait, your phosphorus level is rising, and it's more than this calcium, and the balancing act is now in favor, obviously, of the phosphorus. And so your body's like, I don't want this. What is homeostasis? Well, I need to balance that out. So if you don't consume extra calcium, thoughts to where more calcium might be if you don't eat it. Bones, right? So if left untreated and your phosphorus level keeps rising and rising, eventually your body says, okay, where else can I find this? I will pull it out of your bones, making you osteoporotic. And so why was I giving Tums the whole time? So that it didn't happen. And sorry, I contributed probably to a lot of osteoporosis out there, short term, I hope, but I didn't understand, but now I do. So when you see Tums, give it. Give it, especially if you know your patient is having renal issues. Make sure you give that, all right? And then sometimes like a TUM isn't strong enough for whatever reason, and I really don't remember how Cevimeline works. I know there's other ones, but Cevimeline is another phosphate binder, but it's prescription, not just like over the counter, go to the drugstore and pop a TUMS. And so it's obviously stronger phosphate binder. I don't know how it works specifically. I just know that is one of the ones that we use, and there are others out there. I just don't know of them. But anyways, just going back to a funny story about this phosphorus and calcium relationship, because this will happen, and that's why sometimes if you have these patients who don't like to be compliant with their diets, and then every time they come back for dialysis, their phosphorus levels are like sky high because they've been eating a lot of dairy, which is fortified with phosphorus. Then you might see their calcium levels being not that great because it's trying to bind, and then these guys are people with brittle bones and all this other stuff. So yeah, interesting to think of that. So it's a lot of information, but it's fun. It's fun to talk about one topic, but see where it all connects, right? Who would have thought a question about CVVH is telling you about why blood is wet sitting in a bag outside the human body, and why don't you use anything but normal saline with the blood products, like especially obviously RBCs, right? Because look at all this calcium conversation, calcium. Make sure you eat your calcium. Just a quick funny story. I had a patient many moons ago, probably like 3-4 years off my orientation, who was I know he was a dialysis patient. I don't remember why. Very sick. But every time we would do labs, his phosphorus level would be actually really low. And I think he just couldn't replace him for whatever reason. It might have been a refeeding syndrome on top of dialysis or something. I'm not sure. I just remember every single lab check, low phosphorus, and we would give like 30s and 45s of phosphorus. I forget if it's K-phos or sodium phos. I just remember a lot of phos. It was like every single draw was a lot of phos. And that was back in the day when we did every phosphorus was infused over 6 hours. It's not the same way anymore, but it was always 6 hours. So it takes 6 hours, and then you get your next phos, low again. Another 6 hour infusion. It was like, what the hell? And I remember, I think it was Paul Parker, one of the nephrology attendings, if you don't know him. He came up, and I don't know, if you know his personality, he's kind of like, whatever. Not super excitable. And he looks at me, he's like, just give him some milk. And I was like, huh? He's like, yeah, just give him some milk. I was like, skim milk? Whole milk? He's like, I don't care. Just give him some milk. So I'm like, okay. So I went over to the refrigerator. I opened up a carton of some milk. I don't remember if it was skim or not. And I draw it up in a little syringe. She's like, yeah. And I was like, how much? He's like, just give him the carton. So, shit, next draw after that patient got a carton of milk in their NG tube or OG tube, phosphorus level was amazing. This is why sometimes I'll look at patients that haven't pooped for a while and I'll maybe put some coffee in places like their tubes, their NG tubes or OG tubes, because they're used to having a nice cup of coffee in the morning. Oh my God, they pooped. Right? Or another little trick with that, not so much for these reasons, but when you have a patient who's either hyperthermic or hypothermic. Hypothermic, you have to be really careful with this one, but hyperthermic, I usually grab like a nice ice water, pull it up in their syringe and stick it in their stomach for a little while. And then, you know, after maybe 15, 20 minutes, I'll aspirate. And sometimes if it hasn't gone anywhere, I'll take it all out, throw it away, and then go grab another graduate with some nice ice water. And you're trying to cool off the core, you know. So sometimes you have to like not be so medicine-y and think, you know, maybe the guy just needs some coffee and a newspaper and he'll poop. So this example was, hey, I gave him a carton of milk, and if you look, it's always fortified with phosphorus, right? And there you go, winner, winner, chicken dinner, got it. So, it's a long talk about some stuff. What do you guys want to take a quick? Do you have any questions first? I guess this is the question I would have. Oh, I was going to mention one thing. Let me just pop this off. I just want to go back really quick to the K-phos because I had just mentioned it. So your K, your phos. Now, there's the old archaic phosphorus order for like the fluors. This is, I just wanted to point something out, 22, 44, 66, 15, 30, 45. Peripheral is, sorry, I'm trying to think. This one is 2, 3, oops, 2, 3, 4, 3, 5, 7. So with our order set for phosphorus, if we order phosphorus through the electrolyte protocol, you will see this information saying, here's the potassium phosphate that you're about to run. And it could be sodium too. And depending on, do you have a peripheral line or do you have a central line? And now, based on how many millimoles it is here of the potassium, this is really more based on the potassium, that this is how fast I can run that whole bag, a 250 cc bag of phosphorus. If it's not ordered through that order set, it's going to be the old archaic like 42.7 cc's, which equals 6 hours for a 250 bag to go through. By the way, no more filter. So if you think about potassium just for a minute, you can't run more than 20 MEQs of potassium in 1 hour, right? This is why if you look at the peripheral order for 20 of potassium, it says 25 cc's an hour. It's not because that you can't, it's not for any reason other than the patient usually doesn't tolerate it. It burns, right? Peripherally. So I can run 20 every 1 hour, right? So if you do it centrally, obviously I can run a 20 in 1 hour. I can technically run a 20 peripherally in 1 hour, but it probably hurts like you know what, right? So when you look at this algorithm here, if you have a peripheral versus a central, right? I'm never running more than 20 in an hour in any instance, right? So this is in 1 hour, this is 2 hours, this is 3 hours. A 40, we run over 2 hours. This is a smidge over, right? But in 2 hours, I'm getting 3 here and 5 here. So in no instance am I delivering too much potassium too quickly in any of these scenarios. And again, it's in our electrolyte protocol order set. But when they were, let's say you're doing the CVVH machine, which is what we've been talking about, they're not going to order through that order set. So they're going to just say, oh, I put in for 38 millimoles, and you're going to see 42 points, 41.7, I think, I forget, 41.7, 40, whatever. You're going to see that order over 6 hours. If you can kind of remember this conversation, you don't have to order, you don't have to deliver it that way. I know that's not what the order says, but my point is that's not how that has to work. You can actually give, this is like the old floor order. This is just the standard old order. And again, no filter needed. It's Kendra, my patient has SUPs, enemas with zeros. That's gonna be a coffee and a newspaper stack. You know what's been working really well, and it's, you know, I feel like gingerbread, but it sucks. Milk and molasses enema. I've been doing a lot of them lately, and believe me, they float down Congress Street when they finally start to work. But milk and molasses is a really good one, and you just order it from the dietary office, and they won't give you any, well, they're NPO, or, you know, they won't give you any of that. Just explain it's for a enema, and they know exactly what to do. And if anybody has never done a milk and molasses enema, the milk is, so the molasses is creating a very sugary osmotic change. So you've increased the osmolarity within the bowel. So the water is being drawn out to try to dilute it, and the milk acts as a lubricant to the stool. So it really does work. It might ruin gingerbread if you like it. It smells nice at first, and then not so much after. All right. Well, why don't, if nobody has any questions at the moment, why don't we take like a 15-minute break? Kind of come back at 11:30, or just relax for a little bit. I just need some coffee. Unless you have something burning, I can answer it, but let's take a little break. This is very awkward staring at a screen, I won't lie. How's the neurocritical care group doing?
You've had quite the audience here. People have come and gone. They really loved all your everything you've said.
Oh, good.
The nephrologist listened for a while.
Did I say things right? Are they there?
Yeah, it was
Okay.
about CBVH. Dr. DePerno was listening. He was, I should take this class.
That's awesome. You know, I hope at one point the ICU nurses would be able to actually do the setup, because I feel like, I mean, the dialysis nurses, they're amazing, and they'll tell you themselves, they're like, you guys troubleshoot it, you see it, you run it. So like, we know what the alarms could mean, but people such as myself have like worked with it a lot. You kind of like, oh, okay, I know what that means. And so we can troubleshoot it a lot. So having the ability to maybe even set it up so it takes it out of their hands, because, you know, right now, one of the ways we tend to kind of work with it is on the Monday through Saturday schedule, dialysis is kind of peeking at your flow sheets from afar, and they're looking at your TMPs, they're looking at your flows, like all of these things, and they'll start making decisions like, okay, I think this thing is already in the 300, so what I'm going to do is towards the end of the shift, I'm going to set up a new one so that tonight it should run smoothly. And then other times, if it's like 50-50, they don't know, they'll say, okay, and they'll talk to the nephrologist, and they'll say, call you, or hopefully, if not, maybe give them a call before your shift ends and say, if this goes down at any period of time, sometimes the docs will say, if it goes down after midnight, just return the blood. If it goes down before midnight, I want the dialysis nurse to come back, or 1 a.m. or 2 a.m. because they're coming in at 6. So, you know, they might say, all right, if it went down after 1, just return the blood, because the nurse, you know, that's 4 or 5 hours that the nurse will be back, and then they can just set up a whole new one. But wouldn't it be great if the ICU nurses could do that at some point? Because then that's just one less thing they have to do, but we wouldn't have as long of an interruption with therapy if we could actually set the machine up. And it is, you know, it's step by step. I mean, I've helped set one up a couple of times with the people that I've worked with that trust me. They'll be like, "Hey, go ahead and do it." And the screen literally walks you step by step. Sometimes the wording, you're like, "What does that mean? That's dialysis lingo. Hold on." But it's it's easy if you just like walk through the steps that are displayed on the screen. And honestly, it would take a lot of that untreatable time away where they could get treatment and, you know, get back on track versus, you know, maybe 4, 5, 6 hours before, hey, this clotted off, but they don't want us to reset it up until the morning time. So that's on them, and I know there's talk about change on that, but who knows when and what and how and all those things. But so just as a kind of a blanket statement, if you're using CVH and you're the day shift nurse, by like 6 o'clock, if you haven't heard anything, I would definitely call up to the dialysis unit and say, hey, to whomever answers the phone, and say, I just want to know what to tell the night nurse tonight, like if it were to go down, not, you know, whatever. And sometimes they'll know right away, or sometimes they'll say they'll call you back because they'll just find the nephrology fellow or nephrologist and ask that exact question and then give you the answer. It's just a good way to communicate, because then, you know, if it did go down at 3 a.m., you're not trying to wake up a dialysis nurse to go come in when they didn't really need to, if that was the case. So, but I'm glad you guys are having fun. Are you guys in three, like upstairs neuro, or are you in section 2 downstairs?
Upstairs,
Oh,
because
okay.
we have a little speaker for our neurocritical care runs.
Oh, okay.
With a microphone on it and stuff. So I just pulled it up.
Oh,
Yeah.
under pressure.
Oh, you're a big hit though. Everybody loves it.
Good. I'm glad these are working out for people. I learn a lot myself when I teach. Like sometimes I fumble and learn new things or try to work my own problems out. So it's a pleasure to do them and know that I have some sort of an impact for people to have some good education, but also it helps me grow too. So it's definitely a two-way street. Ashley, I think you were going to ask me something, but I'm not sure. Thought I saw your mic go off.
I started just saying kind of like thank you for doing these again. My brain right now, I'm like rereading the notes from what you were just talking about to fully grasp it, and it's making more sense. But I'm like trying to get some sort of question in my head. The last few shifts were interesting, but I was just laughing again at your story that you told me the other day.
I have to. Oh, wait. Not sure. I remember which one.
With Patty.
Oh. Yeah. That is a funny one. I recommend, if anybody like yourself or again, I cannot remember the room numbers upstairs, but it's the corner one, like 28 maybe, I think 6728 sounds right. But it's that corner pocket next to that little like family room or whatever on the neurocritical care side. So if anybody hasn't seen CVVH or maybe has, you know, and just super unfamiliar, run in the room and just stare at it and kind of like just see, kind of, if you can remember what we talked about and see it. I think when you see it in front of you, it's obviously, for me, I'm very visual. To hear something, okay, but to see it and hear it is so much better. So what I always recommend is looking at the tubings of each of the products. So, you know, the effluent, the yellow tubing, the big one being the white one, because that's your citrate, and seeing how it literally is adhered, like 2 lumens stuck together, going to the patient, so when the blood comes out, you can see it, like how it immediately starts to work. And then putting this concept of calcium being bound, but seeing the cogs, seeing the air filter, I can't emphasize enough that air filter, you really want to pay attention to it, because you'll have one patient, I don't know if I already said this once, I might have, but you'll have one patient where that air chamber, you set the meniscus of the top volume, which should be saline, right to the elbow of that line in from the purple into the air chamber. And you might go a whole shift and never have to touch it. Keep paying attention to it, but you might never have to touch it. You get another machine, on a different patient or whatever, and all of a sudden it's like every 30 minutes that air chamber's like down, you gotta go up, and then it goes down, and then you gotta go up. And it's like, what is different? And I honestly can never get an explanation other than anywhere something gets screwed to something else, that is a possibility of air sneaking in. So anytime you have any one of those Luer lock pieces, and if you look at the tubing to the filter to this to that, you will see Luer locks galore, right? This one's connected to that, so it could be dragging in some air, but it has that opportunity to escape out. It's interesting. That's why it's like, keep an eyeball on that, always, always, always. And not just on the top of the hour. Really, really pay attention to it until you start getting comfortable with it. And like, all right, the last 2-3 hours, it's still at the same spot. I can probably stare at it every hour when I go in to write my numbers down. But did you have a specific question about something that we just said that you're just...
No, I just hopped in a few minutes late, so I was like trying to piece it all together while missing the first 20-ish, 30-ish minutes. I guess like something that I haven't seen a lot that I maybe be beneficial to talk about is the temperature management after cardiac arrest.
Okay.
It's like that boxy machine that's in the room. I haven't taken care of a patient with them. I think I only
Are you
had
talking
one
about
patient.
the boxing machine being the Arctic Sun?
Yes.
Okay.
I only had, I think, like a part of a shift on orientation with it. So it's like one of those things I see in the corner of my eyes, but don't fully understand. I know you put like the pads on the patient, and then that regulates the temperature to the temperature that is desired, but
Yeah. Negative feedback loop. That's what I was trying to say when I was talking about the calcium and phosphorus relationship. Because you just said that and it just clicked in my head. Because this is a feedback loop. So, simply put about the Arctic Sun machine, what's beautiful about that is that it takes all the guessing and trying to figure out where your patient's at out of your hands. You find the set of pads that are appropriate, and it's height and weight based. So instead of saying like, ooh, eyeball, I'm going, oh, I think that, he's a medium or a large, although sometimes when you get to using them a lot, you can tell. But if you're not really sure, and maybe you haven't even seen the patient, maybe they're coming from the ED and you're just trying to get things ready, I would ask them like, what's the height and weight? Because you can call a storeroom. I know you guys have some stock, but I don't think it's like different varieties. I think it's just like maybe a couple of larges or something. I remember looking the other day for a patient, but basically you find the weight, the height, and then you put these pads on, and basically you turn them from one side to the other, and there's a homunculus on each corner of the pads, which says like, this is this leg, this is this side of that body. So you have to like kind of stare at it, and it shows you front and back, so you can be like, okay, this is the one that goes on here on this side. And what you would do is you'd roll your patients on one side, trying to put their back pads on, and kind of like right in the center where their spine is, I'd put one where it kind of goes through, but more a little bit on the downward side, so it's coming here, but kind of like to here, and it wraps around to the front. And then when you turn them to the other side, you don't want them to overlap, otherwise that's going to create a pressure problem. So you want them sort of to butt up against each other without pinching the skin, of course, but just kind of butt up against each other, and then lay that one down, and then wrap it around on the other side. And then the leg one is very easy. You kind of start with the top and anterior part of their thigh, and you would just wrap it around. And when they're maybe don't have big legs, don't worry if it wraps around and it actually folds in on itself. That's okay. You're just trying to make as much contact to their skin, because once you apply the pads, depending, like if you're talking about the patient who cardiac arrested, there is a targeted temperature that we're looking for that's low, right? But sometimes we're not looking for that. Maybe, I mean, I just took care of a recent patient in our unit that he just had a really bad fever. And it wasn't neuro, but even in neuro patients, fever equals bad outcomes, right? We don't like that. And just fevers of 106 are not okay for like a day. So when you exhaust all these other things, you can use these pads not for hypothermia, but for normal thermia. So you can apply the pads to try to get their temperature back to something that's safe for them. And I'm not targeting 33 degrees like I would if a cardiac arrested. I might just target 37, or maybe 36, 36 and a half, whatever. But like I can change what I want. So when you apply the pads, and then you have these big clunky like wire, or I call them like tubes that come up that you snap in each of the pads. If you have a really, really obese patient, so normally you get 4 pads. You get 2 for the upper part and then 2 for the legs. But if you have a really obese patient, there's a additional piece. That's why there's always 6 open slots. There's 2, 2, 2 on each of like the prongs. I don't know if I'm explaining. If you haven't seen it, it's like here's the tubing, and then it turns into like a bigger thing. So if you're looking straight down on it, it'd be like looking like this. And so I would click one set of tubes like that, another set of tubes like that, and then usually it's just that. So it's 2 for the upper, 2 for the bottom. And then if they're like a really obese patient and these don't kind of come, they're just like right here and that's it, then there's a pad that you can kind of put in the middle, and that's where that third hole can come into play. So usually it's just like 2 and 2, right? So 2, 2, and then the bottom 2, and because there's 4 sets. There's for the top of the body and then for the bottom of the body. And what they are is one pushes the water into the pads and one's pulling the water through back out the pads. Kind of like a dialysis machine, but with water, right? Just water going in. And what the machine does is based on the temperature that you are trying to achieve, and sometimes how fast you would like to achieve it, because that plays a part in certain scenarios, then the water will either cool off or warm up, depending, and that machine does all of that work, and it tries to regulate their body temperature. So in the patient who who has a very, very high temperature, I want to get them down quick. I don't care about how quickly we do that. I want them quick. Cooking at 106.7, which was my patient, is not okay, especially for the entire day. That's not okay for your brain or anything. Protein starts to denature, so this is not okay. So when all else fails, put these pads on, and I want to have this machine work as hard as possible to drop their temperature. So water goes into the pad, and depending on what the machine thinks, it will cool the water off so that it starts to cool off his body. And eventually, when it gets to whatever it needs to get to, you'll see it swaying back and forth. So if they don't have a fever anymore underneath, you'll see that it's kind of like hovering around their temperature, give or take, give or take. If it's going up or down, but it's, you have a quickness that you're trying to be concerned about, like how fast or slow do I drop this patient's temperature or raise their temperature, then you'll see it kind of fluctuate as it's going down or up, depending, again, which direction you're trying to go. So the water temperature is important because when you're doing like the cardiac arrest patient, water temperature always is important, but in cardiac arrest, you're trying to get them to 33 degrees ultimately. We can change that. If something bad happens because we are taking their temperature, bringing it down, and maybe now they're having a ton of ectopy and all the crazy things are happening, now they're bleeding, they're like, let's not do that. Let's back up to 35. Let's stop 33. Let's go to 35. Let's change that mark that we're aiming for. But the preset, when you turn the machine on, is literally, do you want hypothermia program, or do you want normal thermia program? 1 or 2. You pick. This is how easy this is. So cardiac arrest, I will go with option 1 and supersize it. I will take the hypothermia protocol. So the moment you open that application up, you get preset numbers. You get 33 degrees as your target and as fast as possible. And then there's a rewarming phase. So the first 24 hours is going to be your cooling phase. So when you hit that button and you're ready and the pads are on, it starts to push the water through the pads, and then as quickly as possible does it try to bring your temperature down. So now what's important is once you achieve that designated temperature of 33 degrees, now it's trying to sway back and forth. Like, if it keeps going lower, your body temperature goes lower. So you'll see it get warmer at points, right? Warmer than the temperature, because now it has to just kind of hold you there. So here's the mindless part. The machine does all that. You don't do anything. So you have to have some sort of, this is the feedback loop, you have to have some sort of core temperature, whether it's an esophageal temp probe, whether it is the bladder probe from the Foley, whatever that method is, and that temperature does not go to the monitor now, it goes to the machine. And then from the machine, does it have a little cable so that it can then display what their temperature is. I will tell you, just so everybody's aware, there is a known discrepancy between their temperature on the machine at the foot of the bed, aka the Arctic Sun, and then what it shows you on the monitor. Can I tell you why? No, I called the company myself. Got nothing. They're like, yeah, we know it's like 0.2 to 0.3 degrees difference. So you could have 38.3 on the machine, and we'll say 38.5 up there. You're like, wait, okay. Go with whatever the machine is. I mean, you can import. We asked that question. I remember Sean specifically, and we asked, and they are okay. Like, you don't have to keep going in and changing the Arctic the imported temperature from the monitor to what the Arctic Sun is saying. Don't worry about that. We asked that question. We got a that's okay answer. So don't worry. But I just want you to be aware that what you see on the screen as their core temperature and the monitor are not the same. And I cannot tell you even why, because that makes no sense to me. But it will import whatever it sees on the monitor like normal. So what will happen is when you have okay, here you are, 33 degrees. Now it kind of goes maybe 31, maybe then up to 35, because it's trying to hold you at 33. It's just But then, we're only 7 hours into a 24-hour cooling process, and you being the patient, gets a fever. Uh-oh. Well, you will not see it because the water temperature is going to keep them at 33. But what you're going to notice is that the water temperature no longer is 31 to 35. Now it's probably 15 degrees, which means it's working really, really hard to keep your temperature 33 degrees. So it's telling you that that patient is trying to cook underneath there. You're not letting them, but they're trying. So that's why we record that water temperatures, because it's kind of telling you a little bit of a story that's in disguise, right? You can't see that they're having a fever because 33 degrees, but the water temperature is 15 versus 28 or whatever, you know what I mean? You might see it, again, initially you might see that dramatic drop when you're first applying, going from whatever the normal temperature is down to 33 degrees in the first place. But once it's achieved that, now you're looking at the stability of those numbers, right? So if it's hovering in that little zone for a few degrees below, a few degrees above, keeping it at 33, great. But then all of a sudden you see a dramatic drop. That means they have a fever underneath. So give them Tylenol. Do the things that you would normally do as if the fever was present on the screen. If they were 39 degrees, give them Tylenol. And what you might see is that water temperatures start to go back up. Oh, I fixed the underlying problem. Maybe antibiotics are necessary too, whatever the process. Maybe it's an aspiration pneumonia. So now we got to give them the Vanc, the Zosyn, the usual dynamites to sort of treat that. So the water temperature, again, tells you a little bit of a story that you can't really see for yourself up on the monitor. It's saying something else is happening. And that goes for normothermia too. Right? So for normothermia, maybe I've targeted it to, they had, my guy, like I said, was 41.3, I think it was 106.7 degrees, right? I just targeted 37. So at 37, if he didn't have a fever, he should be wavering a few degrees above and below, but he still had a very excessively low Arctic Sun temperature, which meant he was still trying to crank out a fever, although his core temperature was still stable at 37. That thing was working hard to keep him there. Does that make sense?
Yes, thank you.
Yeah, no problem. And so, I mean, if you want to talk about the process in itself is, I mean, the whole reason that we do this is to try to preserve as much neurological function. And, you know, I'm not up to date with like the latest literature, but what I can recite, and anybody can correct me if I'm a little bit like old when it comes to, hey, there's new stuff out there, so that's wrong now. But all of this is to correct or try to preserve as much neurological function. And from what I remember is that no one knows what the right temperature is and for how long to do it. So as an institution, we chose 33 for 24 hours. I know other places do 35 for like 12 hours. Some do 2 days or 3 days, I don't know. It's all different and no one knows what is right. But we do know that cold people have better outcomes. You know, this is why people who drown in a cold lake sometimes for a long time, whether that's 10 minutes or something, sometimes actually make it and make it well, right? But what was the factor in there? They were freezing cold, right? So cellular function starts to decrease. So we have chosen that it's basically a 3-day process. It is 24 hours of hypothermia of the 33 degrees, or sometimes again, if something bad happens at 33, we push the number back up, maybe we say 35, but some sort of hypothermic state for about 24 hours. This question, I can't get a straight answer. Some say, and I will ask the person who's actually ordering this. So, you know, if it was Dr. Lurwick or whomever, Dr. Cedar, I would ask them to their face, like, what is it that you want? Because some say that 24 hours starts at the time of initiation, and others say the time of achievement, meaning I start the clock at 24 when I actually hit 33 degrees. Some say it's when you actually started this process. And I know the most recent one I had in our unit just like a month ago, I think it was. The answer I got was just when I started and pushed start on the Arctic Sun. You know, they were actually kind of cold already, which was great in in our favor for this process. But let's say they were 35, which I can't really remember. But when I hit on the Arctic Sun is like, here you go, the clock started. Where other places or other attendings might say, no, if it took you 3 hours to get to 33, now the clock starts running for 24 hours. So I don't know. I don't get a straight answer because I feel like I get different answers. And I think it's because people don't know. I mean, I don't think any one thing has been supported over another. We just know colder for a certain period of time. So once you achieve that desired temperature for 24 hours, wherever that clock starts, then you start to re-warm. And that process, you need to be slow. So when we think about the cold part of things, there's a list. I will tell you in that folder for hypothermia, things are so scattered now. So before in the coordinator office downstairs, we used to have a folder, like a crate that had all of our papers in it, but I used to have a bunch of folders that had the hypothermia protocol, and you pop it open, and it was just like a display of so much information about how to operate the Arctic Sun, what is the BSAS, like all of these things, what is a BIS monitor, all these things that you need as part of the hypothermic order set protocol. There's one piece of I tell you, take this one piece of paper out, fold the book, put it over there, and take this one piece of paper out, because it was the most, in my mind, beneficial. And it was the 8 key points to think about when you start to make somebody cold and turn them into a popsicle. So, let me see I'm not sure if I can remember all 8 of them, but you'll get my gist. So as you get colder, you get insulin resistance. So as they get colder and maybe they were on an insulin drip, you might start seeing that you have to use more insulin and then more insulin, whatever, So now you have a decrease in drug metabolism. So maybe 25 of fentanyl feels to them like 100 now because it's pretty slow metabolism. Wound healing is terrible. You don't clot well, so you're higher prone to bleeding, or you're more prone to bleeding. Your potassium, this is the big one, your potassium goes down. This is as you cool patients. So when you start to, we're going to ask the question, hey, are we going to cool this patient? be like, what is their potassium right now? Because if it's like 3.8, hey, great. I might give them a 20. Might even give them a 40. I don't know. Just seeing like maybe, well, it depends. Are they in renal failure now? Like, I've got to think of all these other things. But just generally thinking, I have to take in consideration that their potassium level is actually going to start to go down as we cool them, right? Sorry, my mind is blanking. What is this? 5 of them. So there's 3 of them that I can't think of at the moment. If anybody remembers them, let me know. Just taking a moment to think. Can't remember. But anyways, there's 3 more. And that's why I say this one piece of paper, you pull it out and it's like, here are the things to think about. So when we cool patients, we worry about cardiac events because maybe the potassium is shifting. Again, little drugs, they metabolize very slowly. They could start bleeding. This is why it's very, very uncommon to do this process with trauma patients. Because why are they here? Because they're some sort of they're destroyed in a way somehow, and they're probably already bleeding. So then we can't really do this because then we might promote more bleeding. So it's a very risk and benefit. Obviously, the attending is the one that gets to decide. I'm not saying we never do it, but I'll tell you it's not often that we do it because they're already at risk for bleeding from all their other injuries. Maybe they have a liver lac, a splenic lac, or whatever, some sort of aorta blew up. I don't know, but we don't want to cool them because they could bleed even more. Oh, it's bugging me. I can't think of those 3. But anyways. So potassium shifts intracellularly, so your serum level drops. Well, now when you rewarm them, you want to rewarm them kind of slow and cautiously, because if I rewarm them very quickly, all of these things go in reverse, and a big one is this guy shooting up. So now that intracellular potassium is going to get shifted into your serum, and now your serum potassium level is really high. So now before you even think about rewarming, you might want to know, where do you stand with your potassium then, because that might already be very high. And if it's high and I'm going to rewarm them, that's only going to get higher. So do I diurese them to get some potassium off? Do I give them the old insulin, insulin and dextrose and calcium combination to sort of, whatever, or whatever you think might be the right thing to do at the time. Or sometimes just watch them and take labs often so that we can just keep a very close eye on, which we do labs often anyways, but maybe even more often, who knows. But just keeping in mind that as you rewarm, potassium starts to go up. It shifts intracellular to the serum. And then we know that cardiac events, and this is where VT can occur. So normally the preset is 0.3 degrees per hour. Sorry, per hour. I don't know why I'm drawing things like that. But 3 degrees, not negative, but 0.3 degrees per hour. So to get them to, I think the pre-default is 36.5. I think that's, oh, sorry. 36.5, I want to say, is the target when you rewarm. So that whole process from 33 to 36.5 is 12 hours. So this nice and that's why I was saying is that machine does that so well for you. So it's constantly waxing and waning with the temperature so that it builds up the temperature. Oh, and then it brings it back because it's getting a little too warm. So they're going up a little too, I'm going to drag you back a little bit, and then I'm going to push you back up and drag you back. So therefore that temperature is always kind of going around and around. Now, it will do it even if you have a fever, but just keep in mind there might be extremes now, especially in the low end, where it has to go up just a little bit, but maybe it's always under the targeted temperature, because if it gets to, let's say you're at 35 and it's going at 0.3, it only has to get to 34 before your own furnace is trying to bring it up higher. So at 34 it kind of slows down and goes back to maybe 25 degrees or something. But it's just constantly waxing and waning, trying to get that temperature up, but very slowly. And then once you hit that target, that becomes normal thermia, and the machine will ding off and be like, ta-da, we've done it. And it dings off too when it's finished 24 hours. It does its own countdown, which is great. And at any point, you can modify these things. So let's say, at 33 degrees, 24 hours has been achieved. And then we say, okay, we're going to start rewarming. And, going from 33 to 33 and a half was terrible. Like bad things were happening. We can change 0.3 degrees to 0.5 degrees. We can change how long we want it to happen, right? We can say, I don't want them to rewarm over 12. I want them to rewarm over 24. I want them to only get to 34 and a half degrees, not 36 and a half. Like we can change all of that. These are just like, you turn the machine on, here is a preset program, and then we can modify it. But once you hit that ultimate goal of, in this case, I'm saying 36 and a half, then at that point, you switch over to the normothermia program. All that's doing is saying, keep you here. Don't move you. Just like as if it was the 33 degrees, except this is indefinite. And this part is a day and a half. So the whole cardiac arrest is a 72-hour period. 24, 12, and then 36. And that's the whole process from one point to the next. After 36, the docs can do whatever. And when you're in the, really in any phase, depending on what's happening with your patient, you can disconnect the patient, like from the Arctic Sun. You leave the pads on, but let's say you got to run over to MRI or CT. They're all compatible with all of those places. You could just empty the hoses, do your thing, come back, hit, and resume. So don't think at any point you can't, but we just know, like, we don't want to interrupt, like, the cooling and rewarming process, especially that rewarming process. I'm sure, if they rewarm too quickly, bad things can happen, especially the cardiac process, right? But we can do that. The point is you can do that. So during that 36-hour period, if they're just maintaining normothermia and they're like, hey, we want to repeat head CT, see where they're at, you can disconnect them and go. And then at that 36-hour point, when you're finished all 72 hours, right? Then, am I doing math right? Was that 36? Someone help me out. Is that 36 hours? 24 and 12, and then the rest of it's 36? That doesn't sound right. Oh, God. You know the difference. For 3 days. I don't know why that's not sounding right in my head. I apologize. But after the full 72 hours, then you can do whatever needs to be done for that patient. So in other words, if they start having fevers after that, then you can just keep the pads on and just keep them normothermic for 5 days if you wanted to after that. I think, if I'm not mistaken, I want to say that the pads, the gel and everything, that they only recommend the pads to be in use for 5 days only because the gel is not that great. And so if you were to continue, then the recommendation would be to take the pads off and just apply new ones. I know they're expensive. I have no idea about the dollar amount. I just know that they're very expensive. So don't kind of use it and think like in half an hour you're not going to use it. Know that you want to use it. And then at that point, the other pieces to this whole process, that's just talking about Arctic Sun, which was your question. But if anybody wants to branch out a little bit, the other pieces to this whole process is that the moment you're going to do this, there's a protocol and there's a lot of just like set things. So, for sedation, because these patients are intubated, for sedation, you do 25 and 25 of propofol, 25 of fentanyl. You put a biz strip on, and at some point neurology needs to be notified and involved because they want a true EEG, not just a biz. So you kind of have biz and an EEG. And at some point when you're getting started, they want what they call a BIS-1, which is you give a weight-based dose of vecuronium to paralyze your patient so that you're taking away all the EMG. So if nobody knows what EMG is, you get a BIS number. A BIS number is your kind of like a percentage, 0 to 100, of how awake you are. I might be borderline 80 at this point. 80 to 100 is awake. Closer to 80, I'm on the sleepy end, right? 60 to 80, I'm like sedated on some propofol. You stimulate, I can wake up. That 40 to 60 is I can go have surgery. I can go get my abdomen opened up and be okay. that's kind of your bottom point in where people should be mainly. But then there are instances where that BIS number needs to be even more suppressed when people have bad ICP problems or profound ARDS, and we know that if they even think about trying to blink, then they will decompensate. So having them completely sedated as much as possible to a BIS of 8 or something might be in their best interest. Generally speaking, this is a percentage, and this is saying that I want to know what their brain function is kind of like. This is this bispectral, only kind of like the frontal lobe information saying how awake are they? And when you give them this first dose of VEC, the EMG is muscle activity. Think about if you were to take your EKG leads and shake them, you would get all this artifact. Well, your muscles, even though they're not really moving much, they still can interfere. So you'll see EMG kind of going up. This is this bar on the screen. And if the EMG is high, that means that BIS isn't accurate because it's saying that this is interfering and it's reading that number as if they were awake and giving brain activity, but it's not. So the SQI, Signal Quality Index, these are the numbers that we're trying to look at. The SQI is telling you how good this signal is. So the higher the SQI, the better you're getting that number. The lower it is means you probably have a lot of EMG giving you fake readings over here. It's like fake news, right? So a lot of EMG, fake BIS. Big SQI, probably inaccurate BIS. So when we vex somebody, we are taking their muscle activity out, right? Skeletal muscle stops moving. And that BIS number is like, all right, without any muscle interference, no fans, no things blowing on it, because if I even do this to the little lead on there, I'll get some artifact. So very placid room. That's like their very initial BIS. So that's what we're trying to do with a BIS 1. After that, these patients, we're turning them into a popsicle, right? So we have their EEG leads on, hopefully. So they're really looking at the whole brain, not just this frontal lobe, and seeing how awake. They're actually looking, are they seizing? Are they doing weird things underneath that they're not showing us because clinically they don't look like they're moving, but they could be having some subclinical seizures, right? So maybe they're seizing and, their little pinky's moving, or maybe their eyes are doing something underneath that you don't even see, but some sort of subclinical seizure. So we're looking for all of that, right? And we have our BIS on, we're getting that information, and then when you're cold, what does your body naturally want to do? It wants to get warm again. And what do? We start to shake, right? So we have a BSAS score. So it's bedside shivering score, or assessment score, excuse me. Bedside shivering assessment score. I'll get it right sometime. And what that means is that there's a scale from 0 to 4. It's really simple. 0, there is no evidence of any sort of shivering. And I can't remember the verbatim, but basically 1 is I can't see a thing, but if I were to touch them, I could feel some shaking. 2 is I think it's like a little bit of like twitching here. Maybe it's the face, I forget. And then the third one is like full on, like you can really see everything moving. If it's a 0, great, nothing happens. If it's a 1, 2, or 3, so basically, if it's not a 0, they get paralyzed. Why? Because they're trying to shake, they're trying to shiver. Shiver is your body's way of trying to generate heat. I don't want you warm, I want you cold, right? And so that's miserable. Can you imagine being like freezing cold outside and for 24 hours you can't wear a jacket, you're freezing, and you're like, blah, 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 blah. That's terrible. So what we've come to discover is that your thermal receptors are in your skin. So we have a cool way of trying to trick your body into thinking it's not a popsicle when it really is. And that is called counterwarming. So when we put a bear hugger and if they already have mitts on, great. If not, maybe a pair of socks on their hands and their feet. But the bear hugger cranked on high because we're trying to trick their surface, their skin, to feeling like it's warm when in fact their core is freezing cold. And this is a way to not actually have to administer as much paralytic because every single hour you're responsible for assessing that patient and doing visible checks for this shivering. But if you don't see anything, you have to touch them. And if at any given point they score a 1, 2, or a 3, not a 0, they get paralyzed, and it's a weight-based dose, and that's every hour. Every hour. So technically, not that they actually do, and because of the counter warming that we've been doing, I've actually seen less of this, but you could actually paralyze them every single hour. Every hour. Because you're trying to prevent them from doing the thing that we're trying to do, which is they're trying to get warm and we're trying to keep them cold. So a way to kind of get around that is to counter warm them, which is using a bear hugger and some socks and mittens, and in the form of maybe some socks from the clean utility room. So, labs obviously play a part in this, paying attention to the potassium, but that whole process. And then once you start the rewarming phase, this one is kind of like, when you hit rewarming, you're kind of thinking, okay, I shouldn't really have to paralyze them. But usually in the beginning, I say usually, I don't mean that a consistent thing, but I will say in the beginning when they're still in that 33, and maybe they're like 33 to 35, maybe 34, depending on, I'll have a conversation. I won't just take liberty to do this myself, but that's grounds for me to kind of still paralyze, because we are trying to rewarm them, but they are trying to jump the fence too quickly. So in the beginning, I will still try to maybe paralyze them if needed, not that they have to. And then once they're getting to like more of like a 35-ish and over, I'm like, yeah, just let them do what they're trying to do. The machine will sort of fluctuate. But I will always have a conversation. Cold, when you're keeping them that first 24 hours, it's no brainer. You're paralyzing if you need to. So not always do you need to. And it's for every kilo is 0.1 of VEC. So if they weigh 70 kilos, it's 7 of VEC. 80 kilos, 8 of VEC, that kind of a thing. I don't remember if there's a cap. I want to say 10 is kind of a cap. Like if they're 110 kilos or something like that. I feel like we do have a cap, but I don't know if there's one that truly exists in the order set or not. But you're trying to prevent them from shivering, which is them trying to generate heat while you're trying to keep them like a popsicle again. So counter warm, trick them. And then the biz, again, you're looking at the biz information on the hourly basis. You're looking at the seizure. Well, hopefully these rooms are the continuous EEG rooms, which have an Ethernet port that hooks up and allows the neurologist to access this server that the EEG is on at any given point from anywhere. They could be in their house in their underwear and looking at my patient's waves and saying, oh, they're having a seizure right now, or no, or those areas where if anybody hasn't done anything with EEG monitoring, there's like a keyboard, and at any moment, like if you're gonna go turn your patient, you just start typing. You don't have to do anything. You literally just go, turning patient, enter. And what it does, it's like a little bookmark for the neurologist to be like, why did this happen all of a sudden on their EEG? Well, I was turning them, or or they woke up, or I lightened their sedation. Lightening sedation. So now they see more activity. Why is there more activity? Oh, I lighten sedation. If you don't do that, that's okay, but that's a helpful way to communicate with them. Or maybe you're seeing something and you're like, is that a seizure? I don't know. So you're like, seizure? ? Enter. And then all of a sudden it's like the neurologist at some point whenever they log on will see that information and be like, no, dummy, that was not a seizure. That was, I don't know, a pled or depleds, or I don't know what the hell they're called. I forget. It's been a while since I had to even think about them. But it's just a good way to communicate with them about what's going on. And if you say like rewarming started, so they can see the patient might be more active, or if you had to go up on sedation, but just little bookmarks for that patient. Just a side note to that, I always get told from the techs when they come up to put the EEGs on, they're like, "Is that a wired room?" I just want people to understand CEEG So there's two types of EEG. There's the 20-minute spot check EEG, which sometimes neurology will order, and then they want continuous EEG, so CEEG. CEEG can happen in anywhere in this hospital. It can happen in the hallway. The part that's missing is that there is no way for the for the attending, the neurologist, to access them live. So the only reason that they say they can't do it, it can be on their head for 24 hours around the clock for days. It's just that at any given moment that they want to look at that information, they sort of have to stop the machine and roll it upstairs, download it, or upload it actually, upload it to whatever, and then bring the machine back and then continue. So it's just not that like, boom, I can see it anytime, anywhere. But just remember, like, a CEEG truly could be anywhere. What they're saying is that it's not wired. So I know downstairs when we go back, I can't say that they won't update this. And all of SKU 2, I believe, was turned into, when they remodeled it, I think they turned all the rooms into wired rooms. Obviously, all of SKU 3 became wired rooms. And I know for us in SKU 4, it was only the back 4 rooms, so 48, 49, 50, 51, were all wired rooms. That meant if someone was down the hall in, let's say, 42, and they wanted to do CEEG, if we could, we'd try to move our patient into one of those rooms so that they would be in a networked room. Otherwise, you could still do it. So that's the piece that I kind of struggle with, is sometimes they're like, you can't do it, it's not a CEG room. I'm like, no, you can do it anywhere you want. You can do it in the parking lot if you want. It's just the point that they can't access it right away. So that means they have to take the time to stop, pull it, bring it upstairs, upload it, which takes a certain amount of time, and then bring it back. So just keep that in mind when people say those things, because I do get a little bit like, just make it happen. We'll figure out the semantics after. How is that? Does that help illuminate a little bit of that process?
Yeah, thank you so much.
Oh yeah, absolutely. In SKU 4, our trauma patients, if they were to code, we're not going to do it as much as like the MICU would do, because our patients are, not every one of them, of course, but a lot of our patients are already having bleeding issues. And so we know that this process worsens that, right? The colder you are, you don't synthesize the proteins the same way. So your clotting factors aren't as effective. You can't clot as well. So that's why it's important in, just a side note for anybody in the trauma world or the surgical world that I work in, or even if you get like, the leftovers, the people that maybe we don't have a bed, now you're getting a surgical patient. If they're already here because they're bleeding, maybe they got in a car accident, have a splenic lac, maybe they had to go to the OR real quick and have an X-lap done or something, you want to warm them up, because if you don't, they're going to keep bleeding. So if they're coming to you at 34 degrees, get some warm blankets, get a bear hugger. Don't just, I'll turn the heat up in the room and like kind of leave it at that. Like, get them cooking a little bit, I'm not saying go get an Arctic sun by any means, but just get them warm, because that bleeding, the risk of bleeding is higher when you're colder. And so it's very important to try to get their temperature back up as quickly as possible. And when you have an acute process like that, like, you had a hemorrhagic event because, you got hit by a car, had a big blood loss, went to the OR, to re-warm that patient quickly is okay, versus the patient that you left for a day at 33 degrees where their body adjusted for it, right? That's why you need to be very careful and cautious when you start to re-warm your patient who has been in a hypothermic state for a day, right? Because this whole process was 24 hours. Does anybody have any questions about what we just went over, or a new question? Awkward. How's the neurocritical care group? I'm gonna keep going back to you guys because I know there's a crew. I'm gonna get a cricket like sound effect for my phone.
All right, I'll ask a question.
Oh my god, thank God.
So I know we kind of jumped around a little bit, but going back to CVVH, do you mind talking, I think one of your Q&As we've been over it briefly maybe, but just talking about the citrate toxicity, if
So no, that's a great question. So okay, so I remember Brittany specifically had asked that question, and honestly, I had never heard that. I've never heard of citrate toxicity. So my educated guess was actually correct, but incomplete. So when I think of citrate and what it does, I'm thinking, oh, your calcium level must be like super low because there's too much of it. So it has to do with clearance. But what's interesting is, so it really does have to do with you have, and I can't remember the exact ratio, but basically I think your total calcium is normal and then your iCal is considerably very low because that's what it's sort of like putting in the Easter eggs. So there's this relationship that's very slanted. But, so that's like, basically like either I am administering too much or my liver is not working fast enough to break it down. So it's kind of like one of these two things. But the other piece to that is that, and this one is, it's like true theory, but how do you really prove it? Our patients are very sick and they're often acidotic for different reasons, but citrate is another acid, right? It's a citric acid. And so you can have a metabolic acidosis accompanied with citrate toxicity, but it's so hard to weed out because they have too many other variables going on to say like that. So I feel like it's one of those things that people know about. Well, not me, of course, at the time, but like it's one of those things where you can have this process blended in with all these other processes also called like septic shock. What is it called? Lactic acidosis. Causes lactic acidosis, right? So is this what I'm seeing, a lactic acidosis, or is this lactic acidosis accompanied with a citrate toxicity because everything's down and my bicarb's down? You know, the only way you could really say it is what it is, like truly citrate toxicity, is the calcium being associated with that, and I think dramatically with that, and all of the other things finally gone away and been fixed, right? So if I like fix my septic shock and I've given volume and maybe I'm not so vasodilated anymore and now I don't have ischemia distally and I'm not in anaerobic respiration, then maybe this is a slant towards your calcium being low, your iCal being low, and I have not the other explanations for a metabolic acidosis. So maybe all of this really is a citrate toxicity. But basically when I asked, I do my phone a friend thing when I don't know the answers. This is what I love about the teaching part is I don't know all these answers. So for someone to ask a question like that, I'm like, who is my go-to? So I give props to Chelsea Wample because I sat down with her after Brittany had asked that question, and it was basically, here's that information, but it's so hard to decipher that because there are almost always these other processes occurring. So how do you weed out just that this is, citrate toxicity? Is this truly just that? So I feel like it's one of these things where it's like that could happen, but can you really tell? I don't know. I think it's one of those things when you have too many things happening and nothing's looking good for the patient as an outcome. It's like, well, let's take that off the table. I think that's one way you can help to tell is to say, well, let's remove the citrate as part of this equation. Does anything change for the better? Or are we still having all of the same things and maybe citrate wasn't a factor, it's still just all of these other crazy processes happening. So I feel like it's by exclusion, by pulling that piece out of the puzzle is the only way you really could tell, or the best way to tell, not maybe the only, but the best way to tell if it was truly citrate toxicity we're seeing. So this is a metabolic acidosis, accompanied then obviously with a giant slant with your, it's like a ratio with your total calcium and ionized calcium. And obviously your ionized calcium being very low. Does that help?
Yes, totally. Thank you.
No, thank you for the questions because, like I said, when Britton asked it, I was like, citrate toxicity? Not sure I've ever heard of it. I don't, because I never come across it. But I know what citrate does. To a certain point. And then after that, I don't know. Any other? Did you have another CVVH question, or was it just that one?
I think just that one.
Okay.
Or,
Well, I don't know. I know Ashley's kind of new. I mean, you've been on your own for a while. Molly, you've been on your own for a lot longer. And I don't know who everybody is behind the neurocritical care thing, but for anybody who's on that more newer side, how are you guys feeling? Like, just in general about being on the floors, doing this, you know, building your relationships with your doctors and obviously your peers in a pandemic. But, you know, are you feeling like okay? Are you feeling still very overwhelmed? I just like to make sure I check in with everybody to be like, let's make sure the psyche's okay.
I feel like at least over on the SKU2 side, I don't know about like how the other units are working wise, but like it was a good unit and everyone's been so helpful. And if I like with the pandemic, obviously we get overflow of like different patient populations. So it's like nice to have like the SKU3ers come over. For some reason, we get a stroke patient because there's no head beds, or like a trauma comes over the SKU2 side, and like there's like always someone to help. But I mean, it is so overwhelming. Like the beginning of my 3 shifts, I walk to work and I'm like, oh gosh, oh my gosh, it's happening. Okay, what am I getting?
That's very unique.
The nerves are still there, but I feel like I'm learning a lot. I mean, still, I learn new things every time, but I feel like it's transitioning well, but still a lot to learn. And these classes are really helpful because it makes it easier to learn in a more calm environment, while like there we're trying to like learn new things while also talking to the new like attendings or residents or anybody who we have to get a hold of, or like any type of consults we make for a patient. So it's nice to have something like calm and relaxed outside of main medical center.
Yeah, oh, go ahead. No, please go.
Oh no, just like that. This isn't like the comfort of our house and we're drinking coffee and like it's just more of a relaxed environment to learn instead of like a crazy ICU setting.
Yeah, I'll speak to that because you know, I've taught basically the moment I got off orientation. Surprisingly, I got handed an orientee about 3 months in, and since then I've taught many people, at least every single year, if not multiple people every single year. So I've had a lot of experience teaching students, and then obviously employees and working. What I learned along the way is how to adapt to people. So I feel like I work with you for a little while, I see how you are as a person, and then I can kind of mold to your learning style. So, and a while back, many years ago, I had a nurse who struggled at the beginning, and I really wasn't sure that person was going to make it. But the drive, the fire in this person was just like, I want this to work. I don't want to give up. So how can I figure out how to make this work? And that was the first time I ever realized that it's so much stuff. I mean, it's not like I didn't already know this, but there's so many bells and dings and whistles and family and patients and call bells and blah, 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 and rounds and doctors and people and hey you, can you, that it's like I can't even remember how to teach, let alone you how to receive the information, because it's like you speak one sentence and next thing you get interrupted. So how is that a great learning style? So I realized that for that person, and what I am getting at is to now, but that person really just needed some like one-on-one, alone, non-distracted time. And that person is a phenomenal nurse and they've been rocking it since then. I feel like I achieved my goal. It was like after doing this once a week for 4 hours outside of the hospital on our day off to just sit down and talk about one body system and drugs related to it, and whatever processes, diagnoses, what do you do, like all of this stuff. It was like the light bulb finally just went on, and I'm so proud of this person, like I really am. And so and they still work here to this day, and I just realized that's what they needed. And what I'm realizing as years went on is that not everybody, I mean, some people can really go with how many distractions we get. But I realize time to time I come across people who need something like this. So my intention for this wasn't to do it a monthly thing, although now it is, and it's wonderful. But it was to just sort of like find the group that was about to graduate, and like at one point there was like 4 of you, at one point there was 7 of you, and say, okay, we are near the end of your orientation. Let's sit down and have this like organic conversation. What are you feeling? How are you feeling? Like, what are the things that you feel like you don't understand or maybe never even heard of before? And let's talk about those things. And that was like my process to start what is now the Q&A. So everybody gets off orientation. We hire people at so many different intervals in time that everybody's time of getting off orientation are all these different times. So it was like, how can I, keep up and make this the most successful thing for everybody? And that's how this evolved into a monthly Q&A, so that at any given moment, you can't make it now, you make it then. You come hear this. And I also want, in case anybody doesn't know this, and I please spread the word, the Q&A specifically is an opportunity for people to come and ask questions, but don't feel like you have to be here for the full 4 hours. You can come in, ask one question, leave. I don't care. This is a very, like you had said, just calm. It's for you. It's a little bit for me too. But it's this opportunity where, if you can only have an hour today because you got to do this, that, and the other thing, come in for your hour. You don't have to stay the whole time. You can come in late and leave late. I don't care. So just make sure, if you know of anybody that is maybe wanting to come but keeps saying like, oh, I won't be able to come at when he starts or something, just spread that word. This is not something where you have to be here for all 4 hours. You have to be here at the start. You can come, drop in for as long as you want, the whole time, part of the time, leave. Come back. I don't care. It's for you. It's for you. So just keep that in mind and spread that word, because I've heard a few people being like, oh, I didn't come because I wasn't going to be there until 11. I was like, that's fine. My other classes, I'd say don't do that. You could, don't care. I don't care who comes and what time they come. There's just an evolution of the material. So if you kind of come in 2 hours on the vent day, you're kind of missing what I've been talking about, and I don't know if you can understand now 2 hours in. So I don't highly recommend coming in unless it's just like you wanted a refresher and just whatever. But the Q&As are for you guys. Everything's for you guys, but it's for whenever you guys need it. So if you can only make it for 1 hour today, come for your 1 hour and leave. Peace out. I take no offense to coming in and leaving at any time. So I just, if there is people that you do know that want to attend and they have that mindset they have to be here for all 4 hours, tell them that's not the case. That's all I ask. It's not the case. So what else? Any other questions? So we got about 40 minutes or so. We can wrap it up a little sooner, but so you have the CVVH. Trying to think if there's anything else surrounding that we could talk about.
Okay, I can ask another question actually on Prisma,
Okay.
I think. I'm assuming this probably doesn't happen often, but membrane rupture, like blood getting in, have you ever seen that? Is that just if TMP goes really high or something?
I can't say that I've had a TMP rupture, to be quite honest. So, the whole thing is contained within itself. Your blood is in the filter, rather than blood dialysate being divided by a filter. So in dialysis, were you here at the beginning of this of the CVVH?
Right, so would that be more of like a like a,
Yes. So, and I spoke of that earlier. So when you have HD, you have a filter and you have dialysate running in one direction, and I believe that's accompanied with the fluid. So that's why they need the water hookups, because the water helps with convection, which is the dragging of the solutes. And so, and if you notice, they just dump it into a toilet, right? Just like plopping around in a toilet. Also, right there, it's disgusting, right? But you have your dialysate running in one direction, you have your blood running in the opposite direction, and that filter, that membrane, the blood and the dialysate never touch each other. But if that were to detect a leak, which the machine would tell you, it's a serious problem. I don't remember what goes into the whole process, but it's a lot. And that, I mean, to the point where it's like an HIV panel, I believe, definitely a hepatitis panel. There's like a lot of stuff, and I believe they start the patients like immediately on antiviral and antibiotic therapies. There's, so there's like lab works and, antibiotics and all these like things that the patient needs like immediately if that were to happen. And so the machine, the dialysis machine, not the CVVH machine, not the one we're running, but the one that they do run, that would say, leak detected. And then that point that there's some process that I'm not 100% sure of all the things that they do, but it is a process. With CVVH, if the filter broke, it's going to leak out of the filter like onto the floor, right? Because their blood's within that system. So I've never seen that. At that point, I would tell you the blood is not going to go back into them. This is the logic in me, right? Educated guess. Your filter cracks. It's now exposed to the air. All you're going to do is hit stop and take the two catheters, like the lumen from the dialysis catheter, forget the Prisma thing, but those, clamp them. And then at that point, so the machine stopped running, you have all this blood that's out of the circuit, but now you've clamped the two dialysis catheter, right? Those two ports. And then you are going to treat them as if you were stopping the blood in the first place. You would disconnect, flush with saline, pack it with the appropriate product, and then put those little chlorhexidine things on. But by clamping it, you are not allowing any more blood to enter nor come out in either direction. But the blood that's in that whole system is now wasted. So if it was cracked open to the air, no one's going to try to chance like, oh, I'm just going to scoot some in. You're done. They lose that blood. That is my educated guess. That would
okay,
be.
got it.
I mean,
I think I was
oh, go ahead.
confused. Yeah. No, thank you. I think I was confusing it. I just read something about membrane rupture, and I think it must have been talking about HD, right? Because that wouldn't really make sense if you're mixing a dialysate with, is that
That,
what
to
you're getting
me,
at?
that's what that's referring to. Because I mean, if the blood is within the filter, so if it's in the filter, it's in like I don't want to show you call the filter a membrane. I guess maybe you do, but the filter that is in HD is not the same. So the product does not touch the blood, whereas in CVVH the product is within the blood, and so therefore it's all contained in the filter. So the only thing to rupture is really the hard plastic on the outside.
Yeah, I gotcha.
And then it breaks, and then you're exposed to the air. At that point, you just shut it all down. But go after, like, hit stop and clamp the two lumen. You know what I'm talking about? The little ones that say, like, 1.9 and 1.8 and those.
Yeah.
Okay. The little
Thank
clamps.
you.
Yeah, you're welcome. It's a good question, thinking of these things. I think it's just the two of you left. Is there any other things you want to talk about?
It's hard for me to formulate questions right now because my patient, I guess the biggest question is so I had a patient with 2 chest tubes, and they were hooked up to the -20 suction, and then you see the orange toggles go up to make sure that they're in suction. There was no air leaks. And then they were draining fluid from an empyema. And then down the hall, like a few steps, was this other patient. And I guess I just don't get how this happens. I like do, but I don't. Or I just haven't thought about it in a while. But like the air, they lock or they clamp the chest tube, and then air ended up backflowing up into the patient and creating the subacute emphysema.
Because they probably saw an air leak. All right. Well, let's draw you a picture.
So like it makes sense when I read it, but I was like looking at the page, I'm like, you are a Rice Krispie treat, but I'm trying to think of where this air came from to push it back into this patient. Because I was like, oh, I get what to do with my other patient, but then I go down and I'm like, oh, I guess that's a complication that I don't want to happen, so.
So, chamber number 1, suction. Chamber number 2, water seal. Or collection, some call it collection chamber. All right, so you have I'm getting better at this. So you have oops. Think of like sack, right? Oh my god, I'm terrible at drawing. Plus this pen is really hard to like. So when you have a hole right here, air is going in, going into the lung, and then escaping out the parenchyma, and then in between that pleural sac, right? So
I'm trying to look at it. I see the lung itself, and I see the lining outside the lung, and then the little bubble within the lung, is that the empyema?
Oh no, I'm just trying to draw like this is the area where there's a hole.
Okay.
So what happens is, this is the obvious part that people usually know, is that as air goes into the lung, it escapes out here, and then it builds up between here and here, and then eventually this lung wants to expand when you inhale, but it can't because it's being forced against this way. So that's when it sort of gets crushed, and now your lung is only this big, right? So when we take a chest tube and we make a hole in this side, it's so hard to draw. Oh, I am better on paper, I promise. This, you make a hole here now, and the air that goes out here gets to get sucked in over here. Okay, and air rises, and fluid obviously is dependent on gravity, so positionally. So if fluid is in the way, like let's say, draw this picture. So if fluid is in the way, and this is air, and this is all fluid, right? And this is the chest tube. The only way to get this air in there is to suck it through. Okay?
And that would be the -20 suction?
Yeah. So when you put them on suction, it's trying to drag the air through. Fluid will passively fall in. So the reason why we often will get, like, let's say you go to IR for just a pleural effusion, like they don't have a drop lung. But we put them on suction because on the off chance there's just like a little hole that someone created when they were like putting the needle in. It's just it's almost like a precautionary thing. It's sort of cultural. Like we throw them to suction when they first get back. Why? It's a pleural effusion. Pleural effusion. You do not need suction for fluid to come out. If you've ever had anybody on water seal, what still comes out? The fluid, right? So the air is what can't, because it wants to rise up, right? So if there's fluid in the way, it has to be sucked out. So when you look at, so this is one way when you have in here, this water seal, you see like blip, blip, blip. This is like the air being dragged out with suction, right? So you see these little bubbles. So if you see the bubbles, that means you have an air leak. But you can have an air leak for a different reason other than having a hole in your lung. You know, if your patient was really edematous, right, a lot going on, and then you take a trocar, right? Let's say we're doing an old-fashioned trocar. So big old stiff catheter, right? That's got some holes in it. So they take this and they shove it up in here, and now that it's kind of like sitting like this in here, and right, and now this is what's hopefully draining the fluid as it builds up, and then the position that you put your patient in, and also any air that rises is going to be sucked through into the system, right? And we know that we make a little incision and we like jam this thing, which is barbaric and a little bit uncomfortable to watch. But we make an incision, and we're like, and we throw it up in there, and they're fingering, just like, okay, yeah, that feels like it's the pleural sac, and that feels like it went up. Oh, okay, it didn't go in the liver. You have to be careful on which side you're putting it on, because you could go over here in the abdomen, in the liver, spleen over here, in the diaphragm. So we want to be careful. But let's say we get it in the right spot. Well, after we're done, they take this trocar, and now I'm looking at it into the body, like not sideways, but directly at the body, right? So the trocar is like this big, and now and then, this is like their skin, not a fried egg, I swear. Then what happens over time is, like, let's say they're getting better, maybe they had liters of fluid, now we're diuresing. The space becomes a lot kind of bigger, right? So it's really tight when we first put it in there. But now think about like deflated around it. So we always put this gauze, right? Not Zeroform. I mean, you can put Zeroform. It's not going to hurt them. But just the idea of just simple petroleum gauze, right? And we take it, and we wrap it around, we smush it. Literally, you want to be very sloppy with it. You want to like just smush it. And by smushing it, if the space between the actual catheter here and this space is completely occluded by the Vaseline gauze, then any air can't enter that space. But if you don't do that properly, and let's say there's just a little bit of area here, then what happens is, if we do a side view, right, and this is your skin, I don't know if I can, oh no, it takes the whole thing away? Oh gosh. All right, well, we're going to draw two then. So this is how it looked when you first put it in, and now the skin is like that. So now there's an opening. Well, the suction, even though the catheter is like this, right? The suction can actually draw the air in from here and then back through the system. But if you weren't to suction, then this can draw the air in, and eventually, if left untreated, you're back to this scenario if you're not on suction. So there's a potential that if it wasn't an air leak from an actual pneumothorax, then was this purely because the dressing wasn't occluding the entry of that catheter, so the trocar or whatever, the pigtail, whichever one you have, right? So that's one way. That's another way that you can have an air leak without having a pneumothorax. And so that's why you have to be really mindful on dressings, because that's what I was trying to say. Like with the gauze part of the dressing, you want to be super sloppy with it. You want to wrap it all the way around the tubing and then literally like smush it down, but not neat and tight and cute. You want it like large and bleh. You want it to really occlude and you want to push it right to the skin, because it is the thing that's trying to occlude any air from getting into that space here. So the area between the skin and the catheter itself, right?
Okay.
So as far as an empyema, if you had, a lung.
So pretty much the person had subacute emphysema because of there was a minor leak between the chest tube and the skin, therefore was pushing that air into the skin.
There could be that. There could have been a very small pneumothorax that maybe wasn't detected on chest X-ray. X-ray. Or was there an issue with this? Like, was there any sort of hole? this is one that really makes me nervous. Is this system gets connected? By 5-in-1, and if people
For like the extension tubing? Oh no, the 5-in-1 on the top of the pleurovac?
not here, up here, so the trocar or the pigtail is sticking out of their body,
Yes,
and then,
okay.
and then it stops, and then it's connected right here, this piece, right? So the 5-in-1. Sometimes I see people. So I am not a fan. I got introduced to the banding gun when I started, and I will tell you, don't use it. It's not necessary. You take beautiful microfoam tape and you overlap. So you start back here and you wrap that microfoam tape around tight to the tube. So a bit past it on one side and a bit past on the other side. And you now have a very, very nice, tight, secured connection between that side and this side. Because what happens is if you undo that whole thing that I just did, if this were to pop out or this were to be loose and pop out, you could be sucking air right through it this way. Anywhere there's, or if you perforated it and had a hole in it, any of these things. So that's why when you change it, what do we always do? We take Kelly clamps and we clamp it here so that we clamp this piece, right? And then we can take this piece away, we can get rid of it, and then we put a whole new system in, and then we unclamp it, right?
So do you usually clamp it twice?
No,
I've been told to clamp it twice, and then someone was like, "Oh no, that's overkill." And I was like, "Well, no, I don't want to."
no, just one. So you just take one way to protect it is to take a piece of gauze. So just go get one of your 2x2s out of the drawer and just wrap it around, and then take your Kelly clamps and chomp on it.
And you want to do it closest to the skin to prevent any of that, like, kind of dead spacey air in the tube to get in.
No, it doesn't matter.
Doesn't matter. Okay, that's what I was about to say. I was like, oh crap, I definitely clamped it. I clamped it twice just to be safe, but like clamped it not
No.
close. Okay.
No. So I mean, anywhere there's a disconnection is also opportunity for air. So it's not just like you have a pneumothorax or you have a ill dressing, like ill fit dressing that's allowing air to be sucked in this fashion. Someone might. So I saw this on a patient recently where they had like the really nice pigtail, and it's kind of got one of those, kind of like the end of a nasal trumpet fitting, and you just jammed the 5-in-1 in there, and that was it. I was like, oh, if that patient like moved and it got stuck and pulled, it would become disconnected, and they would suck air and put air into the outside of the lung, inside of the sac, right? We don't want that to happen. So I took microfoam tape and I wrapped it around. So I go a bit, like I don't just do it right here. I do it a bit on one side, a little further and a little further, so that it's overlap, then over the 5-in-1, and then a little overlap over here. And one just nice and tight to it, and that's it. That's it. You don't have to go back and forth and back. Just one good tight roll from one end to the other. You're good, and that thing is secure. The reason why I hate the bands is because when you do need to change it, sometimes you have to kind of figure out how to get that pointy part of your scissor under there, and then you can't just snap it because you can't fit it under there, so you have to like gnaw at it for a while. And then I have punctured one with the sharp thing because my angle is too steep trying to get in there, and now I put a hole into the trocar part. Easy fix. I cut it, and now I made it shorter, and now my 5-in-1 fits a little bit further up. So that's why I wouldn't start way back here. I'd start over here, because if you run into problems, you can cut your way backwards. Not that that's the thing you should ever really have to do, but my point is that you don't even need to do that. Don't use the banding gun. Just use nice, tight microfoam tape from one end to the other. Not, you know what I mean? Not the whole length of the tubing, just this one area where the 5-in-1 fits to the trocar, and just go a bit past it on one side to the other, and you've got yourself a nice, tight connection. And if anything's going to come out, if it was pulled, it's probably going to come out of their chest, not the actual tape being pulled apart. I'll tell you, that's going to be a lot stronger. So they have sutures that try to hold this tube in place. But again, if you can imagine this piece being gone and this piece being gone, this is air that can get through there if you don't really occlude it well. So that's another way of having air. So if you're like, I shouldn't have an air leak, their chest x-ray looks great, and you're still getting, you're on suction, you're still getting air bubbles over here, then something else is up if it's not a pneumothorax. So is it a loose connection? Is it the trocar against the tissue, and like maybe your wound is opened up a little bit, where the entry point is opened up and is dragging air through that way? Because like, what else? There are other things that can make air in there, not just a pneumothorax. So. And then, and I was going to say, as far as the empyema, if this was, the lung, and then, this is the lung and this is the sac, if you've got this ball of clot here, they're sticking in the Dornase and then maybe the TPA, and what they're trying to do is break this clot down, because if it's a hemopneumo, then obviously the blood sort of clotted off. Maybe we should inject some citrate in there. Just kidding, no, not a thing. But you're trying to break up the clot that's already there, right? So obviously clot buster. So what they actually do there is they inject the Dornase and then at some point the TPA, and they clamp it so it dwells in there for, could be like 30 minutes or whatever, giving it time to really marinate and try to break up the clot. And they do this like over time. They'll do it, maybe a couple times in a day for, a few days, depending on how long they feel like they need to do it. And eventually this thing liquefies and you get the bloody kind of old maroon content coming out of the chest tube. And then hopefully after that, once you really get it all, if you can get it all, then it's, should just turn into the old-fashioned serous fluid. And then to get rid of this, if we are kind of weaning somebody from, if you don't have like this problem here, the empyema, but you have just a straight up pneumothorax or hemopneumo without the empyema, eventually when the air stops coming out is when now you test to see if they can have it to water seal. So you put it to water seal, and what that's showing is if the patient tolerates water seal and then we do a repeat chest x-ray and everything looks the same, then that is an indication that the air part is done. There is no more hole. It's healed up. So then what we look for after that, after we're pretty confident that there is no air leak from that reason, then what we think about is less than 100 cc's in a 24-hour period. Because if we're having still a lot of content coming out, if we take that tube out, it's just going to build up, and then it's going to be restrictive for the for the lung to expand, right? And so, we want to make sure that in 24 hours that we don't really have that much, because if 100 cc's come out, then your body should be able to handle that, manage it, reabsorb it, move it, shift it. But if you have, I don't know, 300-400 cc's a day, that might be overwhelming to that space. So that might cause restriction and compromise to their breathing. This is why when people simply just have a pleural effusion because they're sick, maybe malnourished, not a lot of protein, and they just develop these pleural effusions that you can see on chest x-ray and then maybe even CT scan, what do we commonly do? We commonly will take them to IR and put some pigtails in, not to drain air, but to just drain the fluid so their lung can expand and have a better chance of extubating or not being intubated in the first place, because we're trying to get rid of the thing that's obstructing the lung from moving back and out, in and out, expanding. It's kind of crushing the lung inward. But again, the reason why we would come back from that procedure from IR and put them to suction when all we're doing is removing fluid is on the off chance we didn't notice right away, or a pneumothorax starts to develop, we already have the tool, just put it to suction. So a whole day goes by and none of the nurses claim they've ever seen an air leak. We're great. Just put it to water seal. Now we're just draining and we're trying to get to the same thing. Are we less than 100 in a day? And then sometimes people need it for a long time because they're malnourished for a while. They don't have a lot of protein. Some of that protein, malignancies, if they're inside the lung, draw sometimes fluid there. So this might be a longer term type of device just to get the fluid away from the lung so they can continue breathing okay.
So you would want them to drain less than 124 hours.
Yeah, so like, in your 12-hour shift by, let's say, 6 o'clock, you were doing your I's and O's and you're like this GI stuff, whatever, and you go over to the Plurivac and you just see, you look at the difference and you see the hash mark and you're like, okay, that's 50 cc's. Okay, boom, 50 cc's. And then you pass off to Molly for nights. Molly does her thing, and then at like 6 in the morning before you're coming on, she only gets like 25. Then and then you come back in the morning, and then she says 25. So that's 75 cc's for the day. So that might not be one day where they're like, okay, 75, let's pull it out. They might want to see another day, but the point is that it was under 100. So if it stays under 100,
Okay.
they're very inclined to want to take the device out. Unless there's something
I
else.
don't know why I just thought like 24 hours and 100 cc's. I don't know why my brain instantly went through like within the first 24 hours you want.
Oh, no. Just as time has gone on. So
Okay.
the method of weaning somebody from a chest tube is going from suction to water seal to watching the drainage, making sure that content looks normal. Color, right? So if it was clear, serous and now it's bloody, did something just happen? Or is it irritation? So noting the color. But then the quantity is another factor in deciding. So that's up obviously for the docs. And then every time you take out a chest tube, some say 4, 6, 8, I don't know. Everybody has a difference of opinion. But at some point later, not just like the next morning, do we do a repeat chest x-ray just to make sure their lung is still expanded, that it doesn't look like we gave them a hole, somewhere when we pulled it out. Just another fun fact about chest tubes, though, just in case. So if and I would say more towards nights, although really any time of the day. I just know, sometimes residents are trying to do stuff and we don't have as much support. So just being the bedside nurse, when you're watching somebody say, okay, you know what, this guy's got a chest tube, he's septic. Maybe they put the chest tube down in the trauma bay, and then they're like, hey, we need to run some levo. He's just got a couple of peripherals, and we need to go up, so we need a central line. Unless there's another reason, where should they put that central line if they were going to do it on the upper half of their body, meaning up here somewhere? Where should they put that? Any guesses? Any idea?
I would think probably on the same side, just because they already probably have a pneumo.
Boom!
So you don't want.
Exactly. Unless there's a reason that they're not supposed to or can't, they should try to choose the side, putting it in the triple lumen or whatever, on the same side, because what is the risk of central line access? Well, you got a sharp instrument aiming towards their lung, whether it's subclavian or IJ, right? Not femoral, but these two. And if while they're doing it, what is the risk? Even if they didn't have a chest tube, we run the risk of giving them a pneumo, right? So why do we always check a chest x-ray after we place the line? 2 reasons. 1, make sure it's in the right spot. 2, make sure we didn't blow a lung up, right? We didn't deflate it and now it's like this big over here, because now we got to re-expand it. If you already have a chest tube in a side and you don't have any issues, contraindication that you can't put a central line on that same side, then put it on the same side. Tell them, kind of guide them. Hey, listen, what side are you thinking? Oh, the left? Well, listen, I was just thinking, since they already have a chest tube on the right, if you were to give them a pneumothorax, kind of already got the treatment in place, if you know what I'm talking about. Because otherwise, they pop the left side. Now they have to go do another procedure, which is putting another chest tube in, which in the meantime, if we didn't know, could cause, tension pneumothorax if it wasn't seen and treated right away. It could lead to PEA arrest. Not saying that's like always going to happen, but just that idea. You already have a treatment in place for a different reason, and it's for a pneumothorax. And if you give them a pneumothorax while you're putting in that central line, you've already got the treatment in place. So why wouldn't you? Again, unless there was some reason you couldn't. Good?
Yes, thank you. I didn't really I guess my brain hasn't thought that in depth to think like, oh, the central line should go on this side. That makes sense.
Yeah, because if you drop the lung, you're already inflating it again.
you might as well drop the lung that's
Drop
already
the
there.
same one. Drop it like it's hot.
No, that's helpful. Well, I was just like so that she was like, oh, the nurse was Megan McNally. She's awesome. She was just like, oh yeah, this patient has really bad subcutaneous emphysema, and I was just like, I know what subcutaneous emphysema is, but like my chest tubes were perfect. I didn't have this complication. Now I just am like overthinking, and I was like, ah.
So let me ask you this question: was the patient? Did they have subacute emphysema only after they already had the chest tube?
Yeah.
So I think if this is the same patient, I'm pretty sure they came up from COVID, and
I think it was a COVID transfer.
yeah, I think the doc told the nurse before transfer to clamp the chest tube because they didn't think it was in the right spot. And
So
but it was because all of a sudden the nurse was like, why is her chest like blowing up? And she almost had a tension pneumo because the chest tube was clamped.
gotcha.
Jeez.
Yeah.
So it shouldn't have been.
I'm
What's
sorry.
that?
So it shouldn't have been clamped on transporter.
Probably not.
Jeez.
There are some patients that are that they really need suction for their pneumo, like almost all the time. They're not the type that you could sort of get away with just maybe futzing around the room and you want to just unclamp it for a minute, right, and then put it back to suction. So those types of patients, especially when they're going to go on transport, whether it's CT, back to the OR or whatever, you can order from the OR, I think also CSD if I'm not mistaken, the portable suction machines. They are loud. Oh my God, they're so archaic. They're loud. It sounds like you've got a generator in your bed, and it's like the little cylinder that you kind of, it's like a closed circuit. You put the little cylinder in there, and then you put the tubing that would normally be in your suction on the wall into the cylinder, and then you just turn the machine on, and it creates that suction for you. And it's got intensity that you can turn either higher or lower to gauge what you need. So if you need like the ball in the window versus the bubbling in the wet suction, but just know that not everybody can tolerate just like, oh, I'm going to disconnect you for a little bit and then, and then come back a little bit later and then reconnect it. It's like they will not tolerate a travel to CT and back. They will die. So order a portable suction machine. Definitely order one. So maybe that patient, I don't know that patient, but maybe that patient really had this sub-Q because it was clamped, had nowhere to go, leaked out, right? And then the whole time they actually could have benefited from a portable suction machine, but maybe they didn't look like it based on whatever was happening before. So I can't speak to that scenario. But you just brought up one more thing that I didn't. The one obvious thing is that, the chest tube is not in the right spot. So maybe it's not really in the right area to drain the air, which I didn't draw up here, but that's definitely a very obvious and I forgot, but another reason that you could have air entering that lung, still crushing it and causing your emphysema, your subacute emphysema. So
That makes sense.
yeah.
I guess like another like thing that makes me really, really, really anxious is you hear all like the horror stories of like not charting all your narcotics completely exactly and then your license is revoked. And the other day I had a patient that was going CMO, but all I could worry about was like, oh my God, if I don't chart the 15,000 vials of diuretics, I don't know why the palliative doctor was like, oh yeah, just do 0.5, and then in 10 minutes do 0.5. So I was just doing the same dose of vials, and I was like,
Yeah.
I just don't know how to get rid of that anxiety of like, I don't want anyone, like if I don't want to ever be accused of that, but then I'm also, my brain's not where it should be.
Yeah.
My brain should be with the patient that needs me.
Yeah, I mean, I know more recently we've had, I think, more issues with those things, and I know that obviously there's now a diversion nurse in the mix, and there's things that prompt the attention to that person to then be like asking the manager, talking to them. So when you take out a bunch of stuff, okay, the patient is your priority.
Exactly.
But what you can do is, if you can't chart that right then and there, that's okay. Just keep a running tally of what you gave and when you gave it. So
That's what I did. Like, had a piece of paper.
that's fine. I mean, the reality is like your patient comes before anything. So if you need that, if you need that medicine to keep them comfortable, if they're going through a dying process or whatever, sorry, I'm going to give you morphine in just a minute while you're gasping for air. I just got to go chart this. No. Give them.
No, yeah, like I gave the meds first and like took care of the patient first, but then all I could worry about after was like, oh my God.
That's okay. I'll tell you, I gave the most medicine I think I've ever given anybody to a patient like about a month ago, because unexpectedly he did not pass on as quickly as we thought. And it was just such probably, I don't know, not one of the worst CMO processes I've been in, the fact that he was like rioting or screaming or anything like that. It was that nothing I could give him because of his tolerance and his Suboxone use and everything just wouldn't affect him. And so the thing about that is you want to be careful of what is your dose that you're supposed to be able to give, and how frequent. And if you need to start doing things that are not within that parameter for your order, then you either have the doctors change it, but sometimes you can't do that right now. Like, again, this is not your physician. It might be saying, go ahead and give them another 0.5 milligram or or whatever you're giving, right? So at that point is keep that in, like, write it down on I have like paper in my butt all the time, right? Like I pull it out of my back pocket and I'm like, okay, 0.5 milligram Ativan at 14:12 or something like that. So I have it written down, and eventually when I have the actual real time, I can sit down and then, get all of these in order, right? And then waste what I need to waste. Sometimes you do a multi-dose on something that wasn't multi-dosed ordered, right? But I'm not going to go and take and waste. Sometimes what I'll do is, like, I gave, there's 2 milligrams of Ativan and I gave 0.5. I need to go back and say 0 wasted, incremental doses. And then on the MAR, they're seeing that I gave 0.5 here, 0.5 here, 0.5 here, and 0.5 here. So what I gave and what I took matches. It all just matches, right? So don't stress so much about that. Just make sure it's just all documented. And then if there were things that were like, I gave something when it was supposed to be every 2 hours, like 10 minutes after, and the thing said, are you sure you want to give this because it's outside the time that was ordered? That's okay, give it, because your doctor told you to, so you can write that. And then I write a detailed note at the end. I mean, this isn't a common thing that you're going to be doing for everybody, but I will tell you, when it does happen, you just want to CYA, as they say, right? So it's one of those things where I said, this doctor specifically, give the name, knew, like, this is what was happening. This doctor had ordered this, gave it, and then once I'm done, I make sure the MAR reflects all of those doses that I gave, and anything that was not the full dose, like if it was, you are supposed to give a milligram of Ativan, but it dispenses you 2, and the order says for 1, but you took the whole 2, gave 1, and then a little bit later at some point in time gave the other 1. As long as you scanned that, documented the next 1 milligram, and then went back to that Pyxis machine and did the double signing where it says like waste, you're going to go back and waste 0, but you're going to write the little explanation thing, gave multiple doses, like, and you can write more, like gave it for CMO, CMAR, whatever, just something that's saying, I used all of this, so I didn't waste any of it. I used it for the right reasons. It's documented in the MAR. Here it is. Both milligrams are accounted for in the MAR, and now I just have to make sure it matches now in the Pyxis, which is I used the whole vial, but I didn't. I gave 1 and 1, and then you just weigh 0. That's it.
Okay.
Yeah.
Yeah, that's what I did, but
Yeah. I know everybody. I believe me. Everybody gets very, very nervous. I mean, you're trying to do the right thing for these people, right? You're trying to give them the things that they need, but then you're like freaked out about, well, who's gonna come and get me for what I was doing for my job? And it's the
I know, I
patient
just
what they
hate that
need.
we have that like
Just make sure.
fear that's like always behind us subconsciously.
Here's the thing: make sure it's in the MAR. Make sure the Pyxis like they match, right?
Yeah.
And then if you don't feel confident that just those two things sums up that process, write a very detailed note, as detailed as you can be. And if there's a specific person that has been guiding you, in my situation, use their name so that it's like sometimes we're like, I didn't give sulcrafate MD aware. But who was the MD? That's actually not okay. You really need to specify who
What
was
MD?
it that said that. Because MD
Yeah.
could have been Joe Schmo on the street. Who knows,
I did like a CYA note that was like all like patient transition to CMO, MD Hutchinson aware, and provided verbal orders to give doses, CMAR, something like that.
Yeah. And
Just so, like, I don't know. It just sucks that we have to have that fear when you're not, you're like not doing the wrong thing.
yeah, but
You
see, the
gotta
thing
let
is
it
that
for you.
I think that you know what to do. You're just scared of missing it at one point in time, and that's okay. So just it's like easy to say, right? Just relax about it. You know what to do. So make sure the MAR and the Pyxis match, and that you waste either actual drug or no drug, depending on if you used it twice or how, whatever. And then if that scenario isn't captured by just those things, then write yourself that note.
Okay. Thank you.
Yeah, no worries. So Molly just piece. Do you have something else, or are you good?
No, I think I'm all set. That was just like, that's been my like biggest fear recently is just like, I guess I was like talking to Jackie, I was like, maybe I'm just so novice and like I have such like a innocent heart that I would never divert drugs. So I didn't think nurses actually diverted drugs. I didn't think it was a thing, and Jackie's like, "Oh, honey,
Yeah.
like, welcome." And I was like, "I'm a good person. I just don't ever want to lose my license over a stupid miscommunication over a 1 milligram of Dilaudid."
Yeah. No, I mean
So, like, just took away
the fear is real, but you know what to do.
Mm.
So I don't think anybody's thinking you'd be stealing, Dilaudid or anything, but just make sure you do those things. Out of the utmost, the MAR and the Pyxis match, and
Okay.
then just kind of, for me, my situation. This, like I said, these situations aren't like an everyday thing. My situation is I needed to give more outside of the time prescribed, and my physician was guiding me, literally right there, telling me, give more, give more. So what I would do is I'd say, here, I gave this, write it in, not just the one I scanned in the little comment section, but at the end of the whole thing, I had done like a here's where I am right now note with everything and names included. And then by the end of the shift, because that process wasn't even done, which was very surprising, then I was like, okay, now here's where I am and here's how I'm leaving off. So it was just everything was captured, and that provider actually wrote a note sort of saying like, yes, all of those things that were done I knew about, guided, helped with, needed, was necessary for this CMO process.
Yeah, I asked the doctor, I was like, could you just like briefly write in your note that you like guided me to
Yeah.
give these drugs
Yeah,
in
and
or
that's-
not, like, just like you knew that these drugs were given and that there was like, I didn't give any nurse dose, like,
Yeah. No.
I mean, it was a good situation, but like, I don't know. I just hate that that's like a subconscious fear.
I don't know.
I didn't really realize it until like my patient was like going batshit crazy. But other than that, thank you for the meeting. I'm sorry I was 30 minutes late.
Oh, like I said, don't be. No one has to ever apologize. You come when you come, leave when you want to leave. It's for you guys. It's a 4-hour session for whomever wants to come whenever they want to come. But these are good topics. Like this was a good one. So
Well, I just feel bad. Like, there's so many experienced nurses in here sometimes, so I'm like, I feel like this question's so stupid.
no, believe me, don't ask.
And I
it.
don't want to be
Ask.
like, how doesn't she know this? Like, this is basic knowledge. I'm like, I'm trying.
No, I don't ever think that way because there's stuff that at this point in time I'm like, should I know that already? Shouldn't that be like a nursing school kind of thing? Like, shouldn't I have already known this for like the last 17 years? Or am I, but at this point it's like, if you don't know, you don't know. Just ask. Like, because honestly, it could benefit you, benefit your patient, make it easier for you to take care of your patient, whatever the question is, So,
Yeah. It's hard because I haven't had, like, a patient, I swear, in like a week, or I don't even know, more than like last 3 shifts I just worked over the weekend, and then the other 3 shifts before that I had the same patient. So it was like, I haven't had like a situation where I'm like, huh, I'm wondering what that is. Because I've done kind of like the same things with this patient,
yeah.
kind of turning basty. And just like, there wasn't a lot of, I wish there was something like, ooh, this happened, so I have to like think about it. Like, the biggest thing was transporting them to CT.
Yeah.
But
Listen.
no, I am gonna ask kind of, I don't know. I feel like I can take like one critically ill patient,
Yeah. No, good.
or, yeah.
Maybe.
I say that and then I get nervous, but
And
thank you so much.
yeah, no worries. We'll catch you on the next one.
Yes, thank you. Which one was your next one? Hemodynamics or Ben?
Next week is the hemodynamic class.
On March 11th.
Yes.
Okay, thank you.
Yeah, you're welcome.
Bye.
Bye-bye.